Good morning and welcome to day 2 of the Oley's 2022 virtual conference. You are in the home tube feeding device management session. Thank you for joining us. I'm Joan Bishop. I am the Oley Foundation Executive Director Emeritus, and I'll be facilitating this session. If you are meant to be in the home IV parenteral nutrition session, please call Kathy at the Oley office. Her telephone number is in the chat section. You can find that in the bottom row, and she will help you get to the right place. Presentations from both sessions are being recorded, so you won't really miss anything. The recordings will be available on our website after the conference. As we said yesterday in the introduction, we would have loved to have been in person, but in an abundance of caution for the population we serve, the Oley Board of Trustees and Oley staff made the difficult decision to stick with virtual again this year. But we're grateful to be here in any form. And we recognize that by meeting virtually, some of our members who would not be able to attend in person may not have been able to participate. Also, as said in the introduction yesterday, the Oley board and staff will be working to secure a date and location for Oley 2023, an in-person meeting with a virtual arm. Stay tuned for that date, as we will be sharing that with you as soon as possible. Many of our presentations today will be immediately followed by a live question and answer period. Please note at the bottom of your screen the Q&A function, and at any time during the presentations, drop your questions in there and we'll answer as many as possible. Also note that closed captioning is available. The transcript you'll see is auto-generated by Zoom. We're not able to check it or edit it, and it's often very inaccurate and almost comical, especially with medical terms. So try not to laugh, but it is pretty funny. In the interest of time, I'll be giving only a brief introduction of the presenters. You can learn more about them at the oley.org/Oley2022. It's on the Oley website, conference website. If you need technical support, please call Kathy. If you need anything during this session, please call Kathy. Her phone number is very conveniently located in the chat section. Speaking of technical support, as you may have noticed, we ran into some issues with our social hours yesterday. As a result, we're hosting the Meet the Oley Ambassadors and the Spouse Connection meetings this afternoon from 3:30 to 4:30. Thanks to Homney for sponsoring the Spouse Connection group, and join us. Links to both groups can be found on oley.org/Oley2022. That's the conference landing page. We will remind you again at the end of the day. Also, be sure to check out the marketplace and enter the marketplace challenges. There's prizes to be had. So today, we start our program with recognition of our corporate partners and a word from Oley trustee John Mahalchak.
Hello, I'm Rosalind Dahl. As the Communications and Development Director at Oley, it is my pleasure to thank our corporate partners for the generous support they provide for Oley programs. Truly, we would not be here today without their contributions. Many of our partners have been there for Oley for multiple years. Takeda, 9 Meters Biopharma, Coram CVS Specialty Infusion Pharmacy, Abbott, Baxter, Cardinal Health, Fresenius Kabi, Kate Farms, Option Care Health, Optum Infusion Pharmacy, Avanos Medical, Nestle, AMT, Emerita, Moog, NutriShare, Real Food Blends, and Solio Health. We are delighted to acknowledge increased support this year from Vectiv Bio and Zealand Pharma, and to welcome 2 new partners, MedIQ and B. Braun Medical. We'd also like to thank partners for helping us to reach new consumers, for providing program ideas, and for speaking at meetings like this one. We'll recognize our partners with a slideshow, but first a brief message from Jackie Henze, Head of GI Rare Franchise for Takeda, Oley's Titanium partner.
Hi, my name is Jackie Henze, and I'm the Vice President of the GI Rare franchise and new product launches at Takeda Pharmaceuticals. On behalf of Takeda, we are very excited to be taking part in this conference and honored to continue our partnership with the Oley Foundation. We commend Oley's commitment to enriching the lives of those living with home intravenous nutrition and tube feeding through education, advocacy, and networking. At Takeda, our long-standing commitment to the GI community goes back more than 25 years. We focus on improving the lives of those living with gastrointestinal conditions, including those diagnosed with short bowel syndrome or SBS. We strive to support patients and their families along their treatment journey and believe that no condition, no matter how rare, should go unrecognized. In fact, we recently refined our GI Rare franchise team to focus on people who are impacted by GI rare conditions such as SBS and also complex perianal fistulas, which are considered to be one of the worst complications of Crohn's disease. I'm proud to lead this new GI Rare franchise and look forward to continuing our efforts to make a difference in the lives of patients with SBS and those who care for them. In our GI business and across our organization, we view our world through the lens of patient, trust, reputation, and business, in that order. And you, the patient, always comes first, and that guides our decisions and our actions. We're grateful for conferences like these because they offer us invaluable insights into the challenges that you face day to day. And those insights drive our team and give us a sense of purpose in our daily work. We look forward to continuing to strengthen our partnership and learnings from Oley to better support and serve the SBS community. Thank you, and enjoy the rest of the conference.
Hi everyone, my name is John Mahalchak, and on behalf of my fellow Oley members and consumers, I'm honored to be here with you today to say thank you for your generous support of Oley and its programs. So I first stumbled across Oley in 2017. I was in a difficult spot. My health was not doing too well, my mental health was not doing too well, and I was just searching for resources online to help. And one of the links that came up happened to be to Oley. Also found out at the same time that in a couple weeks they were having their annual conference in Connecticut. So I convinced my parents to pack up with about 2 days notice and head off to Connecticut to attend this conference for a group that I really didn't know much about at the time. And let me tell you, that drive was game-changing. It was life-changing as well. I was around people who understood what was going on. We all had our backpacks on. We didn't have to explain why our pumps are beeping or why we need to take a small break. I was just finally around people who understood what was happening. As soon as I got home, I decided that this was an organization I wanted to continue to volunteer with. So I applied to become an ambassador, and about 6 months later, I was able to start in that role. And it has been amazing, very, very amazing to be able to work with my fellow consumers to improve the quality of care everyone's receiving. Shortly after becoming an ambassador, I learned of some advocacy opportunities that were coming up in this area everyone was calling patient advocacy. I've never heard of that term before, didn't know what it was all about, but as I said before, when to continue to get involved with Oley, I said, we'll figure this out. So I was able to travel down to Washington, D.C. To participate in a coalition of which Oley is a member, where we work with lawmakers on Capitol Hill to improve the quality of care for GI patients across the country. So I was able to go to that, and as I tell the story to everyone else, that's when I got my advocacy bug, got bit by the advocacy bug. And that's something that never would have happened without my without finding Oley when I did. Since then, I truly have embraced working in the patient advocacy world. I enjoy attending medical conferences to talk to other physicians about, keeping the patient front and centered in all care decisions. And all of this, as I said before, would not have been possible without Oley. I go from not knowing anything at all to really growing in this world of patient advocacy, and I credit Oley for all of that. To continue to give back, I recently was also able to join the board of directors for Oley to make sure that a patient voices still remain front and center with what we're doing. So now that I've explained why Oley is so special to me, I just wanted to share a couple other stories about interactions I've had with other folks with Oley in the community and so forth. Probably the one that hits home the most is I was attending, it was another one of Oley's annual conferences, and we were sitting around just kind of socializing. This wasn't a formal session or anything like that. And we had someone came up as we were sitting there talking, and they said, I see you guys are all on, either TPN or tube feeds. And they're like, how are you able to stay, involved in everything? And this particular person was told that because they were on tube feeds, they would never be able to leave their house again. So just by, this person seeing us all there, thriving, made a huge difference. One of the final things I want to touch on, and this is really probably the most important of everything that I've mentioned so far today, is as I'm sure you are all aware, that all of Oley's programs are offered to offered to consumers completely 100% free of charge, whether it be the conference or any of the other resources that they provide, webinars throughout the course of the year, etc. There's absolutely no cost to patients ever. And when I talk to other patients and I start to tell them about Oley, I always really like to mention that, because of our great donor base and our great relationship we have with our corporate sponsors, we're able to offer all these services for patients completely free of charge. And that is something that would not be possible without, all the corporate donations and partnerships really that Oley has with industry. So in closing, I want to just say one more time how grateful, I am as an Oley volunteer, but also as a consumer in the broader community for the generous donations of all of our corporate sponsors and donors. And like I said earlier, nothing that you've heard me talk about today or you've heard other folks talk about would be possible without each and every one of you. And that also includes partnerships that Oley's been able to form with you as well. So with that, thank you so much again for your support of Oley, and I'm very, very grateful. And I look forward to continuing our relationship going on in the future. Thanks so much, everyone.
Thank you so much, John. And thanks to all of our corporate partners, the unrestricted contributions that come to Oley support all of the efforts behind the scene in responding to issues, concerns, questions, hosting meetings such as this conference, and all of the staff time that it takes to pull everything together. So nicely said, John, and thank you for weighing in on the corporate partner contributions to the Oley members such as yourself. And now let's bring John Mahalchak back as he shares with you attendees as to life on both therapies. John, welcome back.
Hi, Joan. Thank you. I changed in everything. It was a quick one.
Very good.
Let me just see if I can get my screen share here real quick. Try that one more time here so you guys can see my slides. I don't know if there's still someone technical staff on here, but it's saying that I'm not allowed to share my screen.
Oh.
I can do it without slides, but
you should be able to now, John.
Okay, thanks so much. Sorry about that, guys. Oh, it's still giving me the... Oh, there it goes.
You're a co-host now.
Let's see, did that work? Can everyone see now? Whoops. Yes. Okay, I'm gonna go. Hopefully
yeah,
you guys can see it.
We see it.
Okay, thanks so much. As Joan said, my name is John Mahalchak. I'm volunteering as an Oley ambassador and newly put on the board of trustees. I'm just excited to be able to kind of share my journey with you guys today. So that's the first thing we'll do. And then I'm going to go over a few tips and tricks I've learned along the way, my 10+ years dealing with chronic illness. I'm going to spend a couple moments on just how patients can kind of get involved with what's going on right now. And then I have a charge for everybody here at the end. So who am I? Before I got sick, I graduated from Allegheny College with a degree in psychology and neuroscience. And then I worked for an autism research project for a couple of years until I got really sick. After that, I was forced to go on disability, and I'll kind of explain that part of the journey here in a second. And then I've been, volunteering my time with patient advocacy ever since, as we mentioned there. And then finally, I do have a passion that I've developed here for helping other patients with chronic illness learn to thrive. So that's me. Looks a little bit different, but I'm going to use this diagram here to kind of help tell my story. So I first became sick in college. I was having severe bouts of abdominal pain and nausea, vomiting. Wasn't really sure what was going on and ended up down at the hospital, and they took my gallbladder out because it was inflamed, thinking, okay, this is a one and done and we'll be good to go. After that, my health kind of continued to deteriorate. I became having these episodes of acute pancreatitis for unknown causes. I had to have multiple procedures done to try to fix it. But over the course of 3 to 4 years, my pancreas had atrophied down to only about 30% of its original size. So because of that, we placed a GJ tube to see if I could get some more nutrients, because I was having issues with that as well from the pancreatitis. But we also decided to kind of do something radical and do a total pancreatectomy with autoislet transplant. So when they do that, they take my pancreas out, they took out my appendix and my spleen as well. And then they place the insulin producing cells from my pancreas into my liver. Excuse me. So that I don't become diabetic, right? Because your pancreas handles diabetes, sugar, insulin regulation as well. So we did all of this and I thought, okay, maybe now I'm home free. And I did okay for a little bit. I actually am completely off insulin, which does not happen very often following this surgery, but I still wasn't able to tolerate oral intake. My body wasn't absorbing what I was eating. So the GJ tube stayed in place, just to continue to provide me with calories. And every once in a while, I'd have to go on TPN as well. Excuse me again. So I was having this issue where the extension of the J kept flipping back into my stomach. Sometimes as often as every couple of weeks, I would be doing my feeds, and then all of a sudden, because of my gastroparesis, the feeds would just fill up into my stomach, and then I ended up vomiting them up. And then we'd realize that the tube had flipped. So with this procedure I had done, my anatomy is also pretty complex. So interventional radiology would have a really hard time sometimes getting that tube to flip back into the right location. So we did all of that. IR at one point finally said, you know what, we can't do this anymore. It's not safe for us to continue to manipulate. So because of that, I ended up having to get an EGD done every time my tube flipped, which wasn't really sustainable. So we decided to do another surgery. And to help with what was going on, we also removed the sphincter at the bottom of my stomach to help me with emptying. And then they redid the attachments in my small intestine from my original surgery. And then at the same time, we switched tubes. So we took the GJ tube out, and now I have a standalone G, which I actually just converted down to a Mickey button about 6 months ago. And I have a standalone J, which is a normal dangler. They don't do low profile for those yet, I believe. And it has been an absolute game changer. And I'll kind of talk more about that here in a second. As I said, we had that traditional tube for almost 10 years, flipped all the time. And we were having issues trying to get it in the right spot. So we talked to my healthcare provider, like, how can we prevent this flipping from happening? These EGDs are not a good idea to continue to do every couple months. So that's when we did the surgery, and we split to the standalone J. So that was about a year ago. And I'm happy to say that I no longer have any issues with feeds backing up into my stomach. And until recently, I was able to tolerate my tube feeds really without any issue. Excuse me. The best part about this one, though, is that the replacements can be done very quickly by interventional radiology. So the piece that is actually inside of my intestine, it's only about like 5 to 6 centimeters from the tip to where the bolster is on the outside of my body. So they can very easily get it in and out. And like I said, that's been amazing because I no longer have to go under anesthesia every time I need a new feeding tube, because these ones are, like I said, done in IR. They don't even use any sedation. So it's a lot better. And like, as I said, I'm tolerating everything much, much better than I was before. So like I said, I wanted to also go over a couple of things that I've learned along the way through my journey. And the first one is the one that hits home to me the most, right? And that's that you can't have good physical health without good mental health. That was really hard for me to say a couple of years ago. You probably never would have heard me say that. I for whatever reason, had kind of a bad vibe about mental health. And then I started going through some major issues, and I was able to meet with a therapist, and it was game changing. As she says all the time, and I always tease her when I say this, but she always told me that, if she met somebody that had my kind of chronic conditions, who wasn't a little bit depressed, she would be more worried about me than she is, with me having some depression. Excuse me. And that took a lot. So I always like to remind folks that there's, you have to take care of your mental health when you're dealing with your chronic illness as well, whether that be a therapist, whether that be a psychiatrist, but it's really important to kind of keep your mental health in good shape as well. The other thing is support groups are amazing, and they're amazing for 2 reasons. And Oley runs a fabulous one as well. Initially, they're great because as someone who's new to the group, you're still learning quite a bit, and you're going to receive lots of good advice from folks in the group. But, by helping to facilitate a couple support groups, I've also realized that it's almost as important for the folks who have been in the group for a long time, right? Because you get to see this progression where you have somebody come into the group who is scared, not sure what's going on, and then, fast forward a little bit, and And now they're the ones providing help and hope to the new people in the group. And it's amazing to see the transformation of these folks who are in the support groups I work with. So if you haven't already considered a support group, I would highly recommend them. You can get disease-specific ones. Oley also offers one that's very well done. So they're amazing, just to help you kind of cope. Excuse me. The last part is to take good notes. And what do I mean by that? So we, at least for me, I'm seeing providers almost once a month, if not a little bit more. It's really hard to keep track of everything. So what I actually did is I have a note sheet that I take with me, and it lets me kind of plan the visit first. So I'll list, what do I want to talk to the doctor about today? And then I'll have a spot for, what did we talk about? What are we changing? What do I need to do after this visit to make sure everything's okay? And if it wasn't for that, I just wouldn't remember. So that format might not work for everybody, but basically it's just good to have kind of a list of questions going in that you want to talk about, because it can be an intimidating situation sometimes. You're in there with the doctor, you only have 10 minutes and then you forget something. So I always highly recommend that people kind of think about what they're going to want to talk about for a couple minutes just before they go. The other part to this that I wanted to mention is, and I'm sure most of you have heard of this before, is this movement called open notes, where, excuse me, where hospitals are now releasing physician progress notes into their patient portals. So you can actually go into your patient portal and see what your doctor put about the visit. It's great to then compare that back with your notes, just so you kind of remember what's going on. And those can also help when you're planning for your next visit. So if your hospital hasn't signed on to open notes yet, I believe it's required by law by now, but everyone's implementing it a little bit differently. So like I said, the last thing I want to talk about was how to get involved. So one of the questions I get asked a lot is, how do you get involved in patient advocacy? And as I said in that corporate sponsor video a little bit ago, I didn't even know what patient advocacy was until I met Oley. I didn't even know it existed. If you would have told me that something like that existed, I wouldn't have met. But I think it's, I always tell people that it's important to keep the patient voice in healthcare front and center. But by saying that, that means we as patients also have an obligation to, when we're able, share that voice. So that's why I'm so passionate about working in the advocacy community. And, it doesn't have to be a lot, right? Here's just a couple ideas that I've put down, but, there's so much more you can do as you get involved. The first is a good plug for Oley ambassadors. We're a fun group, and we get to work with folks who are new to therapy or been on therapy for a while but still have questions. And then if that's too much of a commitment, Oley's always looking for volunteers for other things as well. I'm sure if you called and asked, we would definitely find something to get you to help with. So that's my plug for Oley. I also mentioned how much I love and think highly of support groups. So that could be another way you can get involved, is find a local support group and then volunteer to help with that as well. If legislation is more your thing, you can write letters to lawmakers about issues that are important to you in the GI community. There's a group that Oley is a member of called the Digestive Disease National Coalition, and they work every year. They have a public policy forum in DC where you can go meet with lawmakers, but that hasn't happened since COVID. It's all went virtual. So if that's something that you'd like to do, you can go to their website. They have information about just the different issues that they're working on, with information on how you can write letters to your lawmakers. Cool. And then the last one is kind of new, and there's some people who haven't heard of these before, but hospitals sometimes have things called patient and family advisory councils. So my academic medical center does have one. And basically we are a group of patients and family members from that were treated at the hospital. And we get together every month, every other month, to review different things that are happening at the hospital. We'll look at new literature that's coming out, like pamphlets, things like that. If there's new processes that they're looking at implementing, things like that, they'll come to us as the patient and families to see what we think, see if there's anything we need to tweak along the way. So those are another great opportunity to start. If you go to the website for your health hospital that you go to, I'm sure somewhere, usually near the bottom, there's a link about getting involved, and then they'll have all the contact information there. So that's another good way to get involved in the area. And last but not least, because I think I've been over on time, I just have one charge I want to give to everybody here. So next time you go to your doctor's office, and would you tell your doctor why Oley is important to you, and then ask if you can leave information about Oley for other patients. So if you can all do that, help us spread the word. We can continue to help folks dealing with tube feeds and TPN. So thank you so much.
John, thank you so much for sharing everything that you've shared about yourself and about your journey. I say amen to just about everything, but wanted to point something out that really resonated with me. The Oley Foundation community has been so engaged in offering help to people who are just starting their journey and are worried about the future. They lack the hope in being able to live a full life. And it's been absolutely amazing to witness over my 40 years, to witness how those people who gathered support from others in the community become the support for others in the community just starting out. And it really is, I don't think we've ever had anyone stop and say, no, thanks, I don't think so. I don't feel like helping anyone today. Everyone is so eager to jump in because they know what it's like to struggle at home. So thank you so much. Thank you so much, John.
Yeah, thanks, Joan. Like I always tell people, you guys, it's your fault that I'm here. Because if it wasn't with you guys, if it wasn't for Oley, I wouldn't even know what's going on.
Oh, thank you for saying that. And if it weren't for people like you, I wouldn't be here for 40 years. So thank you for being here. And that message goes out to the entire community. So next, we are going to hear from Vicki Emch, MSRD, who'll be presenting on the transition to ENFit. Vicki's a registered dietitian and vice president of clinical operations and sales support at Aviana Medical Solutions. Unfortunately, well, fortunately for Vicki, she's on vacation, couldn't be here with us today. But if you have questions on something from Vicki's presentation, hold them for Cynthia Reddick, RD CNSD, who will be speaking on venting and decompression immediately following Vicki's talk. And Cynthia will tackle all of your questions. Cynthia is a home tube feeding expert, educator, and strategist who has worked in home care for 23 years. Cynthia works to promote positive clinical outcomes and believes a patient's positive relationship with their feeding tube impacts compliance and quality of life. And that makes sense. Cynthia will be joining us near the end of the program today as well and can answer more questions then. So let's hear from Vicki Emch.
Hello, my name is Vicki Emch. I'm a registered dietitian and AVP of Clinical Operations for Aviana Medical Solutions. I want to thank the Oley Foundation for inviting me to spend some time with you today. And I have a question. Are you ready for the ENFit transition? If not, I'm so glad that you're attending this session. I do have one disclosure. I am an employee of Aviana Healthcare Medical Solutions, and I've been here for about 8 years, but I've been working in home care for close to 17 or 18 years. Prior to that, I was a hospital-based dietitian, and I worked in many different care settings. And here are the objectives for this session. After attending, I hope that you will be able to walk away with more understanding how ENFit connectors improve patient safety. What is the difference between legacy and ENFit enteral supplies, and which supplies will be impacted by the transition? And understand that it's going to be important to clean the ENFit connectors and why this is important. And I know that some of you have heard about ENFit, learned about ENFit, perhaps from your healthcare team, a dietitian that you work with, maybe another consumer who's on tube feeding, maybe even social media. But I thought, just so we're all on the same page, let's talk about why is ENFit important? First of all, there unfortunately are some situations where, or some incidents where a healthcare provider or an individual accidentally connected an enteral supply item like a syringe or a feeding bag to a non-enteral medical line or piece of equipment. They accidentally infused formula into the wrong place, into the wrong body part. This contributed to a poor outcome, and then sometimes it was actually fatal. To reduce the risk of this happening, an international team of experts came together and they created a unique design for enteral supplies, or for tube feeding supplies. This unique design will only allow an enteral piece of equipment or enteral supply to connect to another enteral piece of equipment or supply. This will prevent consumers and caregivers from accidentally infusing tube feeding formula into the wrong medical line or the wrong body part. Now, with these new enteral connectors, there's definitely going to be some benefits. It's going to make it difficult, if not impossible, for unrelated medical delivery systems to connect together. It's also going to standardize how enteral supplies are connected across healthcare settings. And this is something that I'm excited about. I can't tell you how many times that I have worked with a patient, a consumer, somebody on a healthcare team, and we're trying to figure out why something will not connect to another thing. Sometimes it's because it's a specific brand of a feeding tube and you have to use a specific type of syringe. That is going to be no longer a problem because the ENFit connector design will connect to any brand of feeding tube, will connect to any brand of syringe. It is going to make it so much easier going from the hospital to the home and trying to give you the right type of supplies. It's also going to decrease accidental disconnections, reduce those interruptions during feeding. And I know some of you experience this. You set up your feeding pump, you insert the bag into the feeding tube, you set run, or you think everything's going great, but you come back later and you realize the formula didn't go into the tube. It actually went onto the floor or went onto the bed. This will really reduce that. No more feeding the bed. So now we know that consumers are going to get the nutrition that they need, but also it's going to reduce laundry. Anytime we can reduce laundry, that's a good thing. So let's take a closer look at the ENFit design. If you look on the left side of the screen, this is just a diagram of what a traditional, or what we're now calling a legacy tube, what it looks like. There is a stepped adapter that connects to feeding tubes by inserting straight into that feeding port. You compare it onto the right side of the screen. This is the ENFit connector. And instead of inserting straight in, you're going to use a twisting motion to connect. They look really, really different. And that's on purpose. Here is a close-up. These are two NG feeding tubes. On the left side, this is the legacy. Here's that. There's the feed port, there's the med port, and there's a wide opening. That's where that end of that stepped adapter would insert directly into that feed port. You compare it to the right, and you can see this is the ENFit connectors. And you can look at that, that feed port, and you can see that there is, I like to refer to it as a stem. There's almost like a stem in the middle of the port. They look really, really different. So that is the true difference between legacy and ENFit. This is that's the difference in how they look. Here is a photo of legacy versus ENFit and how the syringe is connecting to the feeding tube. Again, on the left side of the screen is the legacy connection. Here's that 60 ml cap tip syringe. It's inserting directly into that in that feed port. I'm sure many of you done this many times. If you look on the right side, you can see how a 60 ml ENFit syringe is going to connect to an ENFit feeding tube. It's going to twist in there. So you can see that the connection looks really different. Now let's talk more about the transition. So the ENFit transition is really picking up speed. Now, when I look back, I remember 2015. I remember learning about ENFit and thinking, wow, this is going to be really great. You know, it's going to improve patient safety, but it's going to be a big change. So we need to start educating our internal team. We need to start, you know, working with patients so they understand the change. Again, this was in 2015. There was some roadblocks to converting over to ENFit. But the supply manufacturers, like the pump manufacturers, they really got on the ENFit bandwagon right from the get-go, and they redesigned their feeding bags to connect to the ENFit tubes. But they knew that it was early in the transition. It was going to take the hospitals a while to convert over to ENFit, so they added a white transitional adapter to the end of each pump and gravity feeding bag. They've been doing this since 2015. Now, this transitional adapter was only a temporary solution. We thought it would be just for a couple of years, but now it's the summer of 2022, so 7 years down the road, that transitional adapter is still on those feeding bags, but change is coming. This summer, both the pump and gravity bags for both of the two major pump manufacturers, they are going to stop adding that transitional adapter. Also, some of the legacy tubes, feeding tubes, are also going to be discontinued. But let's take a closer look. Let's take a closer look at the ENFit US conversion rates. All this picture here shows you some of the top hospitals across the country. Here's the best children's hospitals, the top 25 children's hospitals for GI and GI surgery, the top 25 hospitals for neonatology, and the top 25 adult hospitals for GI and GI surgery. You can see from this graph here that the vast majority of them have either converted over to ENFit or they're in the process of converting over to ENFit. So with this transition, which enteral supplies are going to be changing? Well, pump and gravity feeding bags are going to be changing now. In fact, some of you may actually have feeding bags or pump bags in your home that no longer have that white transitional adapter. G tubes, J tubes, and NG tubes will be transitioning over to have that ENFit connection. They're going to have those connectors for their med port and their feed port. You may actually have an ENFit tube right now. Now, one thing I want to make really clear is that the low-profile gastrostomy tubes, or what we like to call buttons, the design of that tube is not changing. Instead, it's going to be the extension set that will have that ENFit connector design. So the med port and the feed port and on those extension sets, that is actually what is changing. To go along with the change with the feeding tubes, the syringes are changing, so we will have ENFit syringes, feral valve relief bags, enteral drainage bags. In fact, many of the enteral drainage bags right now are already ENFit compatible. And then also some of the accessories as well, like the Lopez valve. If you use a Lopez valve, it will also come with that ENFit connector design. So this is these are all of the enteral supplies that are going to be changing. Let's take a closer look at the Moog Infinity feeding bags. Here's some close-up pictures will really illustrate what has happened or what will happen very soon. On the left side, this is a picture of a 500 ml Moog pump bag. You can see there's that white transitional adapter that is on the end of that tubing. Now, if you compare it to the picture on the right, this is what that feeding bag is going to look like now. There's going to be no white transitional adapter. Instead, at the end, there is going to be a purple piece that you're going to twist in to your feeding tube. With the Moog Infinity feeding bags, they are actually changing the item code number. So the bags that have the white transitional adapter, they're an INFO 500-A. That just tells me that the transitional adapter is still connected to this feeding bag. Now, if you compare it to the one that doesn't have the transitional adapter, it's INF 0500-E. You may see that listed on your case of feeding bags, and that is one way that you'll be able to tell, does my feeding bag have a transitional adapter or doesn't? So that's just a little helpful hint there. Now, if we go to the Kangaroo Joey bags, you can see basically the same thing. So with the Kangaroo Joey, here's a picture of their feeding bag with that white transitional adapter on the left, comparing it to on the right. So they look identical, except there's no white transitional adapter. The item code numbers for the Joey feeding bags, they're not changing. Instead, what they have done, they've put a sticker on the outside of the case, and the sticker says, this product does not contain that transitional adapter. So that's what you really want to be looking for. If you see that yellow sticker and it says this product does not contain that transitional adapter, it will not be on any of those feeding bags. Let's take a look at the ENFit transition schedule. We're going to start out with the Infinity pump bags, the 500 ml bags. They have already transitioned over, so they no longer can have that white transitional adapter attached. Many of you, if you're using that 500 ml bag in the home, you've already received these. The next bag, or the next size that's going to transition over, is that 1200 ml bag. We're anticipating that to transition sometime in mid-August. So it really depends on your home care. If your home care orders directly from the manufacturer, you might see it a little bit earlier compared to a home care that may get their feeding bags from a large distributor. The Infinity Gravity bags, they're going to be a little later, probably more like late September, early October. Now, for the Kangaroo Joey pump bags, all of the feeding bags are going to be transitioning at the same time. The 500 ml, the 1000 ml, the feed and flush, and we should start seeing those very, very soon. Again, anywhere from mid-August to late August. And also, Cardinal, who makes the Kangaroo NG tubes and G tubes, they have decided that they are going to discontinue making legacy tubes. So we should see that also in August or early September. You will no longer be able to find a legacy NG tube or G tube. So I know some of you will have some questions like, well, how will this impact me? What if I have a legacy feeding tube? What am I going to do? So here's like if you take a look on the right side of the screen, this is a picture of that transitional adapter. If you have a legacy tube, like if you have a legacy G tube, a J tube, your home care company will be able to provide you with a transitional adapter that you can easily twist on to the end of your pump feeding bag, and it will look just like normal. You can insert it into the opening of your feed port, and you should be good to go. Now, for if you have a low profile gastrostomy tube or button, what a lot of home care companies are doing, they are providing you with ENFit extension sets. Remember, the button design is not changing. What is changing is the extension sets. So it makes perfect sense if you have a button that you can use your ENFit extension sets. You will be able to connect to that feeding bag that no longer has that transitional adapter. And once you have those syringes, those ENFit syringes as well, you should be good to go. So that's what a lot of home care companies are doing. Now, one thing I just want to bring up is the transitional adapter is only a temporary solution. We know, because we've heard this, the home care community, we've heard this from the manufacturers that they're still going to continue to produce the transitional adapter, but they just don't know how long it's going to stay in the supply chain. We're expecting it to be for at least through the rest of the year. But if you have a legacy feeding tube, now is that perfect time to start having that conversation with your healthcare team about maybe it's time that I need to convert over to a ENFit tube. So start having that conversation. Again, some other questions about how this may impact you in the home. In the beginning of this transition, your home care might give you a combination of legacy and ENFit supplies. Now, if you receive ENFit syringes and you have a legacy tube, and you may panic, well, don't, because if those ENFit syringes can be used with the legacy tube if you have that white transitional adapter. That white transitional adapter can be twisted onto the end of that ENFit syringe, and you can see from this picture over here, it can easily be inserted into the opening of that feed port. So that is a solution. If you do get ENFit syringes, you can use that. You can use that white transitional adapter to make it work with the legacy tube. Here is I just want to take one more close-up look at the difference between the ENFit design and the legacy design. This is a picture of two extension sets. Just like those ENFit, just like those NG tubes that I showed you earlier, it looks almost identical. On the left side, this is a legacy extension set, and you can see that nice wide open port right there versus the ENFit. And you can see there's that stem, and there is also a space in that around that stem. That space is what we're referring to as a moat. Okay, remember that. Because now we're going to talk about why it's important to clean your med port and your feed port with your ENFit tubes and extension sets. This space, or that moat, that's where formula and medication can accumulate. And if you don't clean out your feed port, your med port on a daily basis, that formula and medication can build up, can get all dry, crusty. You know, it's not good from a bacterial standpoint, but also it can lead to difficulty connecting. You can just imagine if there's some dried up formula and you are trying to insert the end of that tip of that feeding bag or a syringe, you may actually have to give it a lot of extra force or pressure. Sometimes this can actually damage those ports, can actually damage that feeding tube or extension set. what we recommend is to use a clean toothbrush to clean out that feed and that med port at least once a day. You want to wet that toothbrush with water. You want to get in there and you really kind of want to scrub it around. Rinse out your toothbrush. You want to do it, do it again, and then you can take a syringe and actually squirt in some water to make sure you get rid of all the debris. There's actually an ENFit brush that can also be helpful. You're really going to have to ask your home care company if they provide that. A little bit more about cleaning ENFit tubes and extension sets. The extension set ports, just like with a feeding tube, they can be cleaned using a toothbrush. But also, I think it's really nice to take that ENFit syringe, fill it with water, and make sure that you flush out that ENFit extension set to make sure you get all of that, the residual formula out of there. It's really important to maintain the life of your extension set to make sure that you clean them after every single use. And another tip is to avoid priming the formula to the end of the pump or gravity feeding bag. This can lead to a buildup of formula in the moat. When you first prime your formula through your pump bag or your gravity bag, sometimes formula will drip out and the little drips can get into that moat. So be a little careful about that. And also, there is a great organization called stayconnected.org. They have some really great resources on how to clean your ENFit tubes, how to clean the ENFit extension sets. There's a step-by-step handout, goes through all of the steps that you need to take. I put in a couple of links here, but this will be really helpful for you. Now practice changes at home. This is a change. And it's going to take you a little bit of time to get used to things, just like anything, just like any change. But I think the most important one to really incorporate is cleaning the med and the feed ports. Make that part of your normal routine. It's only going to take a few more minutes each day, but it's so important because it's going to make sure that your ports stay clean. There's going to be a decreased risk of bacterial contamination, plus it's going to lead to a better connection. And remember, do not over tighten. This may lead to damaging the feeding tube or the extension sets. And this last tip is not just for ENFit, but if you are using a home blenderized formula, invest in a high quality blender and strain any of those fibrous materials before infusing the blends. This will really help prevent the clogging of ENFit connectors. And like with any change, preparation is key. So anticipate the change. Your supplies may look different. And it may actually take a few days to adjust to using the ENFit supplies, but be patient. Because if you're patient and give it some time, you're really going to love this connection. It's so secure. If it's really snug, it's going to reduce all of those accidental disconnections. But if you have questions about ENFit supplies, begin having those conversations, those discussions now with your healthcare team and your home care company. If you do have a legacy feeding tube, now is the time to consider getting it changed over to an ENFit feeding tube. And I do have to say one thing, I do want to mention one thing about medication syringes. From a home care standpoint, insurance reimburses the home care companies for the syringes that are used to administer tube feeding formula. However, they do not reimburse or they do not cover the medication, the smaller syringes that are used to administer medications, because they're assuming that you're getting those medication syringes from your pharmacist or the pharmacy that you work with. If you use a lot of medication syringes, again, now is that perfect time to start having those conversations with your pharmacist. If you don't know where to start, there I'm including a link to this handout that helps guide you on what kind of conversation you should be having with your pharmacist. Let them know that, you know, you use these syringes to administer medications into a feeding tube, and that the type of connections have changed and you need a very specific type of syringe. You can provide them this handout. Begin having those conversations now with your pharmacist. And I do want to close with some comments that we've gotten from some Enteral consumers across the country. This connection feels secure. I never had one break or leak, and my toddler can't unscrew it. And you know those toddlers can be ingenious. So that definitely is a benefit. It's so much easier to use ENFit rather than those other adapters, which are often taken off and I can't find them. They get lost. And I actually love that I love the connection. It would not come apart on its own, and we are no longer had to worry about the med port accidentally popping open and making a mess. And that definitely is a benefit. I want to leave you with some ENFit resources. As I mentioned earlier, stayconnected.org is a great place to find more information about ENFit, the history of ENFit, the why of ENFit, why it's important. But also they have some really great resources on how to clean your ENFit feeding tube and your ENFit extension set. I'm also including some links to Moog Medical, which makes the Infinity Pump, and Cardinal Health, which makes the Joey Pump. They both have some excellent resources to help answer some of those ENFit questions you may have.
Good morning, everybody. Let me do a quick audio check. Let me check in with Joan and make sure you want me to dive into some of this Q&A on behalf of Vicki, who did such a spectacular job with her presentation.
You sound great, Cynthia.
That'd be fantastic. That'd be fantastic. I want a quick message that Vicki's presentation, along with her slides and the list of all the resources, will be available on the conference website shortly after this the conference is over. Thanks, Cynthia. Welcome.
Thanks for having me. First of all, I just want to thank you for having me here. I think one of the things that we all have in common, everybody in these virtual rooms, I think we're all equally passionate about what we're talking about today. So it's great to be here. But I want to dive in. Vicki did an awesome job. It's the first time I've seen that presentation, and I thought she covered it, the A to Z, really well. But there's some questions that popped up here. So the first question, and I think she addressed this, but let me tackle it again. So Bethany's asking, will the ENFit extensions prevent leakage more than the other ones? And so the answer to that question is it depends on where the leakage is occurring. But if the leakage is occurring because of an accidental disconnection, then absolutely it will, because you have that more secure connection between the feeding set, between the drainage bag, between the syringe and the actual feeding tube. So I would say absolutely. And then Jody's asking, she says her husband has a legacy G tube. Can we just order the transitional adapter? So Yes, so, and you may not even have to order it because you may have some in your house and you don't realize it, but this is a legacy G-tube. And to convert it to ENFit, all you do is put this guy in there. And that's if you have a balloon style, right? Because you can't disassemble this type of feeding tube, it's all one piece. You don't ever want to cut this or try to remove, it won't come apart for you to switch out the feeding port. But to convert a legacy port to ENFit, it's very, very simple. And that's basically what the pump manufacturers and the bags have been doing for us. We just didn't notice because this thing showed up at the tip of the feeding bag. So, and that's what's going away. And there was a comment in the Q&A or in the chat actually where somebody's delivery just showed up without with feeding bags without this little transition adapter. So it's happening. It's kind of around the time frame that we anticipated. All right, so next question, is the ENFit connector more likely to cause the tube to clog since it's no longer wide open? So that's a great question, and I think we actually had 2 people ask that same question, so that seems to be kind of a hot topic. But this is not generally where clogs occur, so I want to be clear about that. The clogs generally occur in this zone, and it's usually related to medication, either not being ground up enough or combining like combinations of medications sort of crushed and flushed together. That's often a culprit. So this is the zone in which clogs usually occur. So an ENFit tube like this guy, so this is the same manufacturer, same tube basically. This one's legacy, this one's ENFit. You know, the key thing is really looking at, if you have a history of clogging tubes, you might want to look at a larger bore size or a larger French size of feeding tube. So this one is an 18 French. This one is a 20 French, and you can see 18, 20. So the bigger the number, the bigger the size or the inner diameter. So that's a possibility, but really prevention is key with regards to flushing. Just really good flushing techniques before and after medication, and not piling your meds together and trying to flush them all together. So that's my PSA on clogged tubes. All right, so Susan's asking, we use a urinary leg bag to drain a G-tube because it drains better. Is there an adapter to connect them? The opposite of the stepped adapter. Yeah, and I'm actually going to cover that in the next presentation. So I might just be able to transition nicely into that, but I will demonstrate that for you. Okay, Anna, I love my ENFit extensions, but I've not been able to get my hands on medication straws. It's a pharmacy item, that is correct. And pharmacies say that it is an Enteral home health, so it is very circular. So in many cases, that's something you will have to find. My recommendation is go online to find those. They're not very expensive, that you can reuse them, they will last you a long time. If that's something that you need, then have that in your toolkit at home. All right. So David's asking a question about accidental dislodgement is the word I'm looking for. So because of the ENFit secure connection, is it possible to have an accidental dislodgement of a feeding tube because it is so secure? And we have not heard a lot of that. I think that dislodgement usually occurs because of a deflated balloon or a ruptured balloon when you've got a balloon gastrostomy tube. But I think what we're finding, because most people, when they have a legacy connector, in my experience, is that people tend to make it secure in their own way because of their history of accidental disconnection. So I've had patients that have taped the connection to the point where it may as well be ENFit because it's so secure. And then there's a clamp that is used called an AMT clamp that actually clamps the tube onto the feeding set to keep it from coming apart. So I think the secure connection with ENFit is not a new concept or it's not a new risk for dislodgement. So we really just want to promote safe handling of the tube and securing the device if there's a risk of that sort of accidental tugging, or if you've got somebody who is going to be reaching for the tube and potentially pulling it out, and that's when low profile devices are sometimes considered. So that's sort of a big answer for a little question. Okay, so Terry says, I use my legacy dangler for venting and draining only. So tried a button with the ENFit extension set and it did not work. The bore of the ENFit is so tiny. And had to go back to the legacy dangler. And bore is key for venting and draining. So this is something that I want to touch on as well a little bit in my next presentation, because the answer to that is it's not a one size fits all. And depending on your need for draining and how often and what you're draining, you have to sort of customize your prosthetic to your needs. And this is a concept I'm going to touch on a little bit here in the next presentation. I think you guys did a spectacular job of timing our presentations because you're teeing me up very nicely. Okay, let's see. Okay, Linda, you're doing a great job. So she's been saving her adapters that come with the syringes that are not used. Can you donate them somewhere? Why, yes, you can. In fact, there is an Oley exchange, supply exchange that I think would be a wonderful place for that. Let's see here. Okay, so Terry, you're asking a good question here. So when you use your dangler for output only, so you're not feeding, you're just using your feeding tube for drainage. And so now you get sort of carved out of this tube feeding support, which is where a lot of the expertise is, because you're just using your feeding tube for drainage. How do you tap into that expertise? Your supply provider may or may not, if all they're doing is shipping you DME supplies for drainage, they may not have the expertise for the stoma site care or leaky tube issues or all of those things. So it's the best thing I can do is just get to know your community, and this is true for everybody on this call, really, just to get to know your community, where the tube feeding and tube experts are. Sometimes it's a physician, sometimes it's a GI physician, and you're going to meet one of those here coming up in a little while. Dr. DeLegge is a GI physician who has a passion for feeding tubes, right? Not all GI physicians have a passion for feeding tubes. So look for that person. It could be an interventional radiologist. It could be a home health nurse. It could be a clinic nurse practitioner, maybe even a pediatric specialist who can take their experience and apply them to your situation. So sometimes it's a wound care nurse. Sometimes, it's a dietitian, like a home care dietitian. So it just depends, because not everybody leans into that role of becoming a tube feeding expert as it relates to, even if they work with tube feeding patients, like if they're putting feeding tubes in, they're not always the ones that actually know how to manage the ongoing. They're expert at putting them in, but maybe not the management of them. So, okay, gosh, these questions just keep coming in. So let's see, I think we have time for a couple more. So just setting expectations here.
Cynthia, it's Lisa. Would it be helpful if I posed the questions to you?
Sure, you go for it.
Okay. Well, actually, I know that you're going to be presenting on venting and decompression. So shall I skip that one, the drainage?
Let's see. Well, yeah, let's skip it, because maybe we can answer it in the Q&A there. If it's still an issue, ask the question again, maybe. That way we can. Okay, let's do that.
There are still a couple of concerns about dislodgement that there are a couple in the chat, and I urge you again to put things in Q&A, because we can't always see things in chat and we may be missing questions. But somebody said that they're going to be taking a train from New York City and they're afraid their tube is going to get caught on something and become dislodged. They do have an ENFit connector. So I don't know if you have any tips on, I know that there are some tips on the Oley website about how you can, use a belt to keep it close to your body so it's less likely to catch, or any thoughts on that?
Yeah, so my first thought is, and I think there's probably some consumers in the audience who've had this experience. If you were planning to go out of town and away from your network of support, bring a backup tube. So that's part of your planning. And because tubes become dislodged, whether they're accidentally pulled on or if the balloon, like a lot of people have balloon style tubes, those balloons pop sometimes for no reason. Okay, you could just be sitting there doing nothing, reading a book, and that tube, the balloon could rupture just because it's reached the end of its life. And now you have a tube that's falling out. So it doesn't happen only with accidental like tugging or getting caught on things. Okay, this is just a normal, I shouldn't say normal, it's just an expected thing that will occur from time to time. So what you do is you make sure you get that tube right back in there and you tape it down. And then if you're skilled at replacing your own tubes, then you set a time and a place for that. And if you're not, then go into, generally the ER is kind of the best way to get that taken care of. So that's my main suggestion, is make sure you're traveling with a backup tube, and carry your adapters, right? Because I think there was a comment in the chat earlier where there was a consumer who was traveling with an ENFit button. Actually, the button fell out during a trip. And when she went into the ER and the hospital to have her tube changed, because she's out of town now, she's in a completely different state, she gets a legacy tube put in, and all her supplies at home are ENFit. So it's just really smart to keep these adapters handy and in your supply kit. So the same way that you carry a charger for your iPhone, I don't know about you, but I carry a backup battery sometimes if I'm going on a big trip. So these are the adapters you want to keep handy and just in your emergency kit, the same way you would have tape and gauze or extra syringes.
So Cynthia, I would recommend that you go to your venting and draining that talk, and then we can maybe address a lot of these questions. I know you're doing the show and tell.
Yes.
And I think that we can maybe save some of those for there, if that sounds good to you.
It does. I'm counting on you to keep me on time here. Let's see here. All right, so here's my email in case any of you have follow-up questions. Jot this down. I can put it in chat later too as well. Here are my disclosures and what I'm going to be talking about. I just have a quick few minutes really to cover this, so I'm going to go over some of the rationale. This does not impact everybody. I recognize that. I also recognize that there are a mix of audience members here. There are consumers on the call, there are clinicians on the call, and so I try to present this in a way that meets all of your needs in terms of education, because when I was a clinician in the hospital setting, I understand the concepts, but until I really kind of laid my hands on it, it's a little harder to imagine. So let's go over the difference between venting and draining, because these words are used sometimes interchangeably and they're a little bit different. So venting is this process of removing excess air from the stomach, and what that does is helps relieve fullness and bloating, that sensation of a gassy stomach. Sometimes we call it burping the tube. So consumers call it that, sometimes clinicians call it that. And the thing about venting is it can happen before a feed, it can happen during a feed, or it can happen after a feed. And you don't have to you can be a bolus feeder, gravity feeding, pump feeding, everybody can vent, whether you're using your tube for feeding or not. So lots of times people who are actually feeding into their stomach need to vent. And then sometimes there are people that don't use their tube at all, the G tube at all for feeding, but they still need to vent it, because what's happening right now with me talking to you is I'm talking and I'm swallowing air and it's going down some into my lungs and some of it goes into my stomach. So that's just how it goes. So that's the venting process. And then draining is basically removing excess food and or liquids from the stomach through the G tube. And it can provide relief from nausea, from that feeling that you have to vomit related to a motility issue like gastroparesis, or if you have an obstruction, so whatever your situation is that has you using that G for drainage and either feeding through a J tube, or maybe you're on TPN and just using that G tube for drainage. And that can be done as needed. So what we're used to in the hospital is this continuous suction of a G tube, right? So that's a very standard protocol in the hospital when you've got somebody who we're trying to, you know, not have anything go through the stomach. But when patients stabilize and they go home, then drainage, if drainage is needed for long term, it can be done continuously, sort of like venting, or it can be done on an episodic manner. Okay, whoops. Okay, so the technique. So you can vent several different ways, and I'm going to kind of talk about them, and then I'll try to demonstrate them for you. So venting technique is an open port, which is basically you know, open the port of your G tube, and you can vent that way. So if you sometimes get reflux out of the tube, you can squeeze the tubing and then open the port and then slowly open it up and burp the tube. Lowering it and raising it allows you to vent any gas that's building up in your stomach. You can also use a syringe and using it like a funnel. So you can plug just the barrel of the syringe, taking the plunger out and plugging that syringe in. And sometimes you'll have a little reflux of liquid, gastric juices, sometimes formula, sometimes nothing, sometimes it's just air, and you can actually hear it. And, you know, by lowering and raising that syringe and repositioning, that can allow you to burp your tube or vent. And then you can also use a manual technique with this, what I call a syringe pull. So with the plunger completely in, inserting, and then slowly pulling air out of the stomach. And that's just going to be different for everybody, because sometimes you won't get any air and you just immediately start suctioning liquids out. And so that's just something to keep in mind. Sometimes you can get air out, sometimes not that way. And then there's the feral bag system, which I'll demonstrate here in a minute. And that is a continuous, and that's designed for pump feeding. It could also be used for gravity, but if you're using a bag to feed where there's a continuous drip going, that feral bag is an option to continuously vent while in the midst of a feeding. And then drainage techniques are similar, right? So you can open the port of the feeding tube, and some people, I've seen some people drain directly from their feeding tube into a container, into the toilet, sometimes into a glass, you know, whatever you need. And that's just a positioning thing where if you need to drain and offer yourself some relief, that's an option. And then again, the syringe pull method is another way to pull the contents, the liquids out of the stomach and offer some relief that way. And then there's the drainage bag system, which there have been some questions about. So in remembering that, you know, your stomach is a reservoir, and you may have things to drain, but you didn't eat, and that's not uncommon because our stomach is a manufacturer of liquids all day long, up to and over a liter a day. Liter and a half a day is not an uncommon amount of gastric juices that your body and your stomach has to manage. So if you are having a flare and your body is, you know, the last 2 weeks you've been doing fine and not needing to drain and offer that relief, but maybe you're flaring if you have gastroparesis, and now you need to offer yourself some relief, and so you might drain in that regard. And so I would say that in general for draining, it's basically you have to get in touch with your body, and you may have specific orders when you're first coming home from the hospital, but usually in the long term, it becomes a very personal experience when and how you vent and drain. So there's not a lot of instruction or prescription around it. It's really something that you design around your own needs. All right, so with regards to what I want to try to do see here, is show you the feral bag. So, and tell me, Lisa, if you feel like you can see this okay. I can see myself, but I just want to make sure you have good visibility as well.
Yep, done. Maybe we could, are you done with your sharing your
Oh, yeah.
screen, Cynthia?
Yeah. Let's do that.
Great.
Stop video. No, not stop video. I'm
Cynthia,
gonna stop.
I just wanted to mention too, I've dismissed a couple of questions. I just feel that maybe this isn't the forum for discussing the pros and cons of ENFit and maybe some of the limitations of ENFit. In regards to venting and draining, it seems appropriate, but not overall philosophy. So I don't mean to disrespect anyone who's posted questions that I've dismissed at this point, but I just think that we need to stay on task and address the topic at hand.
I have not been given a lot of time to cover this, so I completely agree. And there are some very specific things that you can do related to ENFit and connecting, and I'll touch on that for you. But let's talk about drainage. So here's your feral bag. This is designed for venting, okay? There are some people that use these for drainage, and it's not a great option for drainage because it's not reusable. This is a little vent at the top of the bag that allows the gas to release in the midst of a feeding, but because of this, it's not something you can't empty this out like you can a urinary drain bag. So it's really designed for that specific case where you're pump feeding and you hang this bag up and then you actually connect your feeding tube, you connect your feeding set from the feeding bag into the feral bag. And this is an ENFit connector. And then the end of the feral bag is what actually connects to your feeding tube. Okay, and so this system allows for you to feed continuously via pump, but then also vent at the same time. So that's the design for these. And the one other comment about feral bag and draining, because it's just something I've observed over the years, is that it's not a great option for drainage because look how tiny that tubing is, where when you look at a drain bag, like look at the difference between the tubing. That's pretty significant, right? So a drain bag is kind of a better option than a feral bag for drainage. And I have a couple of examples of drain bags. So for our legacy tube users, we have been for many, many years using these urinary drain bags. So this is a 2-liter bag. It's got a valve at the bottom that allows you to empty and reuse. And these are also way more cost effective in the home care setting than a feral bag. So I want to be very specific about that because it's something that we saw that got confused a lot. So this drain bag is a 2-liter drain bag. The tubing is a lot shorter than that feral bag system. Becomes, very large if it's something that you're trying to use for drainage. But this connects directly into, if you're going to keep a legacy tube for drainage, this connects directly into the legacy port that way. So if you wind up in the hospital and you come home and you wind up with an ENFit feeding tube and all you have are legacy, an ENFit feeding tube and all you have are legacy drainage supplies, then this is the device that you will need, which is an adapter that turns your ENFit feeding tube into a legacy port and then allows you to connect to your urinary drain bags for drainage. Okay. So again, re-emphasizing the need for this supply kit to have these little adapters handy. And these can be washed and reused. These last a really long time. So it's not going to be a big burden that way. Just keep them handy and have them around that way. I have another drain bag, which is smaller. So there's lots of different options. I just have a couple here, but this is one that doesn't have lots of tubing. It's very straightforward. This connects to the feeding tube. This is a 500 ml. And then this valve just opens up, drains out. And then you can empty and reuse, wash and reuse. And for drainage, you don't need sterile bags. There's nothing going into the body. This is all coming out. So these do not need to be sterile, and we don't have to worry about that. You can rinse them out and, you know, keep them clean that way. But so that's something to keep in mind. And then we also have ENFit drain bags. So there are a lot of these patients that are starting to transition over to these. And so these are for our ENFit users. And it's nice because if you have an ENFit feeding tube, and you need to drain, then you just connect. And the feedback I've gotten about this connection that people prefer is that you don't get that accidental disconnection. So that accidental disconnection happens with feeding, but accidental disconnection also happens with draining. And I almost feel like that is a bigger insult to the day, quite frankly. So, and then to drain, you have a valve here that allows you to open up the flow and empty, and then that locks it back up. So if you have a legacy tube, so if you go into the hospital with a legacy, or sorry, with an ENFit tube, and then you come home with an ENFit tube, then you have a situation when it comes to draining if you've got ENFit supplies. So what you would need is your little transition connector. Pop that guy into your G-tube port, and then you can connect.
Cynthia, it's Lisa. May I
Yeah.
ask a question?
Sure.
A couple people are wondering how they could get the enteral bags, or who makes them, or the drainage bags.
The drainage bags. So the ENFit drain bags, or any drain bag?
I think the ENFit.
Okay. So yeah, there are a couple of manufacturers right now. So I've got Vesco makes an ENFit drain bag, as well as a company called GBUK. McKesson has an ENFit drain bag now. So we had sort of a dry spell where we didn't have any ENFit bags for a little while, but now we've got several options in the marketplace. So working with your home care company to order those ENFit style bags for you is the way to go. And if they don't have them yet, then ask them to bring them on board. What other questions? And how are we doing on time, Lisa?
Well, I'm going to ask Don if our next speaker is on the line, and if he is, then Joan can introduce him, but otherwise I think that you could address a few more questions.
Cynthia, I'm going to jump in here, and I just wanted to ease some of the concerns of attendees in that we realize it's a known fact that often you cannot vent and drain with ENFit, and that legacy tubes will continue to be available until a solution is found. So I think that will put everyone at ease.
Yeah, and I think that, so you bring up a great point, and maybe I'll conclude with this. So kind of going back to this idea that, you know, when you're early in your tube feeding journey and device journey, you don't have a lot of say about what tube you wind up with. So as you sort of get set on your path and you understand what your needs are, you have to have the ability to drain and vent. Then you get to decide what sort of device. So if you're using a low profile device and you have to drain a lot, that button and extension set may not be the best option for you. So you may want to switch over to a dangler style tube, has a larger French size. It's just easier to drain in a lot of cases. And if that's what your needs are, then it's probably more about the low profile version versus a dangler version. And it's your prosthetic, you know, it's your life and it's your lifestyle. And it's really important that you get to have a say in that, especially once you know what your future is going to be as it relates to needing to vent and drain and how often. So that's kind of what I wanted to say about that.
I think until we hear from Dr. DeLegge, who's traveling.
Okay.
Okay, I guess he's ready. So I
Okay.
think we'll switch, and then, so Joan, you can introduce Dr. DeLegge as planned, and then we'll address all those questions. You actually have a lot of questions after your show and tell at the end of the day. Thanks.
All right. Thank you.
Hello.
Good. Actually, our next
Hello.
presenter, oops, excuse me.
No, it's Dr. DeLegge. I was just letting you know I'm here.
Yes, good news. Good news. And actually, Dr. DeLegge, you really need no introduction. This young man, Dr. Mark DeLegge, a gastroenterologist, hepatologist from Charleston, South Carolina, has only over 35 years of clinical experience. He's a professor of medicine at the Medical University of South Carolina. And without further introduction, let's hear from Dr. DeLegge on the G and J tube.
Thanks, Joan. So, Joan, I hope that your team can help me with advancing the slide. Let me know when my slide is up, please. Are we ready to go?
Yes, looks like we are.
Okay, so thanks everybody. This is Mark DeLegge from Charleston, South Carolina. And Joan and Oley had asked me to speak today to this group specifically about a tube system called the GJ. So for those of you who are familiar with feeding tubes, some of this may be redundant, but let me just give you some of the vernacular here. So we all know that a gastrostomy tube or a G tube goes into the stomach. And we also know that a jejunostomy tube or a J tube goes into the small bowel. And so we call those G tubes or J tubes. And depending on how they're put in, they could be endoscopic G tubes, or they could be surgical G tubes or radiologic G tubes. But what I'm going to speak about today is gastrojejunostomy, and we call that a J tube. And so this picture that I have here essentially shows you that there's a tube that goes into the stomach, and you can see that, I hope, with a little balloon on the end. And then if you follow that black line down through the stomach into the small intestine, that's the jejunal feeding part. So these tube systems have two pieces, or they're composed of two components. One's a G tube and one's a J tube. And when they're made by the manufacturer, the J tube is made to fit within the G tube. And I'll show you some pictures of that. And there's some differences where the J tube can be removed in some systems and you're left with just the G tube, or the tube system is all one piece. May I have the next slide? So I've been asked this probably 1,000 times, is what's the benefit of having a GJ system versus other systems? And so the major benefit is that you can feed into the small bowel and you can decompress the stomach at the same time. So these tube systems have an opening in the stomach, and then they have a second opening in the small intestine. Some people, in fact, will use their G port or their G tube to deliver medications through. But essentially, the major benefit is that you have a two-tube system through one hole in the abdominal wall, so one entry point in your abdomen. One part of that tube goes into the stomach, and the second part of the tube goes into the small intestine. I've seen many patients that have two separate tubes. So they have one tube in the stomach and a separate tube down into the small intestine. And that's another way of accomplishing exactly what I'm talking about. However, this system allows you to do both with one tube, essentially. Again, with an opening, which we call a port into the stomach, and a separate opening into the small intestine. There's also downsides, though. So the J tube in these GJ systems tends to be small. And we talk about smallness in terms of sizes, French sizes, and there are 9 or 12 French generally. That's pretty small for a tube. So one of the issues is that they can clog. This is the jejunal feeding part, can clog. And that's a problem because, in fact, if it becomes clogged and then you can't unclog it, then the entire tube system needs to be replaced. And the second downside is that if you have somebody who is having a great deal of nausea and vomiting, then the J tube, the part that's down in your small bowel, can actually be vomited back up so that it now sits in the stomach. And so the J tube, or the tip of the J tube, is no longer in position. May I have the next slide so I can give a little better detail on that, please? So right now you should be seeing 3 different tube systems. And I lay these out here for you to show you that there's a low profile GJ system. So you can have a low profile device, or what some people might refer to as a Mickey, which is a brand, or some other devices, but or a button. But these are low profile devices, and you can actually have a low profile device that's the G tube, and then a smaller J tube that goes through the G tube and then goes through the stomach all the way down into the small intestine. And generally those systems are one piece, meaning the J tube and the G tube are manufactured together. They're adhered together. And so when you want to change the J tube, you have to change the entire system. In the middle, you can see another GJ tube. And again, this is a one-piece tube. It shows a balloon internal bolster. So the part that's to the right there is a typical PEG tube. And then what goes down through that into the small intestine is the jejunal feeding tube. And again, this is a one-piece system. We're looking at the middle diagram that I have for you here. And when you look at the ports, the feeding ports there, you can see one says BAL for balloon, one says gastric for gastric, and one says jejunal for jejunal. And so you would use the balloon port to inflate or deflate the balloon. If you wanted to feed into the stomach or give meds or decompress, you'd use the gastric port. And then if you wanted to feed into the small intestine, you would use the jejunal port. And again, the two systems on the left, the low profile and the one piece, are single systems. What I mean by single systems is everything's molded together, everything's manufactured together. If you want to switch out the G tube or you want to switch out the J tube, you have to remove the entire system and replace it. On the extreme right-hand side of your slide, so at 3 o'clock, is a two-piece GJ system. And you can see here that the J tube in this system is blue, and then the PEG tube you can see clearly. And so the PEG tube is put in first, and then the J tube is put through the PEG tube down into the small intestine, but it's two pieces. And the advantage of the two-piece system would be that if you were no longer needing the jejunal feeding, you could remove the J tube and then still have the PEG tube in place. Or if the J tube got clogged or obstructed, you could remove the J tube and then still have the PEG tube in place, and then have to replace just the J tube portion into the PEG. So again, that's a two-piece system, but it does the same thing. It allows you to decompress the stomach and feed into the small bowel. I have the next slide, please. So I'm often asked, well, why would I want a PE GJ system or a GJ system? Why not just have one tube into the stomach and a separate tube into the small bowel? And what I can say to you is that if you have somebody who requires jejunal feeding and some gastric decompression, the PEGJ system is a great system. However, if you're going to have someone who is going to need their jejunal feeding tube for a long, long time, what I mean by that is permanently, I have not found these systems to be as good as a direct or a J tube, meaning that, yes, the GJ systems work. Yes, you can feed into the small bowel, but after a period of time, these J tubes, because they're smaller, tend to become occluded or clogged and need to be changed. And also, as I had mentioned to you, if you have someone, which may be yourself, and you're having frequent nausea and vomiting, the J tube can be vomited back up from its position in the small bowel, back into the stomach, and then you no longer have a GJ system. Might I have the next slide? Before I move forward, Rosalind or Joan or anyone else, I'm going to stop here for a second. Are there any questions about what I just discussed?
There is a question, Dr. DeLegge. I'm not sure if it's appropriate at this moment or not. It is that somebody has a J-tube mini, a J-tube low-profile device in their jejunum, and they're wondering if they could add a G-tube to decompress. Is that?
Yes. Yes. So let's just say you had a jejunal feeding tube, or that could be a tube, or it could be a low-profile device directly into your small bowel. And then, you know, for whatever reason, you needed suddenly to decompress your stomach. You were having problems with nausea or vomiting, and you needed to decompress your stomach. Since the J-tube is already there, the low-profile tube, they would be best served by having a tube placed directly into the stomach. So essentially having two tubes at two separate locations, as opposed to going and using this GJ system. I hope that answered the question.
Thanks. That, yeah, we can get it. The person can rephrase it if that wasn't the answer they were looking for. Oh, she says it did. Thank you. Another is, are French sizes for J tubes that are not part of a GJ system larger than those that are? In other words, if you have a separate J tube, are French? Okay, got it.
Yeah. So the answer to that is yes. So if you go back in time 20, 30 years ago, when surgeons used to put J tubes into people, they would always put in a very small tube, like the sizes I'm talking about, 9 or 12 French. And again, those are relatively narrow tubes. When we talk about tube sizes, the manufacturer is actually talking about the outer diameter of the tube, but you know, there's wall thickness. So the tubes have some wall thickness to them. So when I say 9 French, it is 9 French, but that's the outer diameter. The actual inside of the tube is probably more like 6 French. So very, very small. And today, many of us will place larger tubes into the small intestine, such as a 18 French tube or a 20 French tube, simply because we know that these tubes have a propensity to occlude. And so we do use larger tubes. I've not seen larger tube sizes like that be available for the GJ systems.
Thank you, Dr. DeLegge. We'll throw one more in now and then let you continue. This one, I have never drained in 3 years. Is that unnormal? I use a gravity bag for feeding and a bolus. I said, if I use a gravity bag for feeding, must I use a bolus wider tube extension rather than continuous feed into my low profile device? Does that make sense?
Yeah, it does. But I don't, so I would say is, no, I don't see a reason why they should have to do that. And in fact, if they haven't had to, I don't know what system they have, but let's just say they had this is a person who had a GJ system in place and they hadn't drained, I think you said to me, for a couple of years. You know, they may not need that system anymore. They would just, you know, if they're feeding into their small bowel, maybe all they need is a jejunal feeding tube, or if they're feeding into their stomach, all they need is a PEG tube or a gastrostomy tube. They wouldn't need to have any other special devices.
Great, thanks. And then I think there are several questions. I don't know if you want them now or if you want to continue going on.
Sure. Sure, I can take just a couple more, then I'll move on.
Okay. My daughter's experience is that nausea was worse due to less effective drainage with a GJ versus separate G and J, but she also has problems with the J. Is there a solution for better drainage from a GJ?
Yeah, so here's what I would say to you is, and I say this with all the love in the world to anybody who puts these systems in. When you're putting these in radiographically versus with an endoscopist, typically you're going to different portions of the stomach because you're going towards what's available to you, what you can see. So for a gastroenterologist, you're looking for a kind of a location on the abdominal wall that you can identify because you're inside the stomach and you can see exactly what you're doing. When you're a radiologist, you're using imaging, you're using fluoroscopy and some contrast. And I have found for people who have had issues with drainage, and again, this is my personal experience, it's been much, much more common with the radiology place tubes, the GJ tubes versus the gastrostomy or endoscopic place tubes. So what I would say to you is, and maybe what you can do is give them my email address. I know you have that. And if they want to email me, it'd probably be a great question I could take offline and get some more details.
Okay. I'll post my email address in the chat and then encourage anybody who wants to pass a question on to Dr. DeLegge to email it to me and I will pass it on. There are a couple of questions about interventional radiology and placement. So it looks like that's what you're going to address next.
Yeah, I'm actually going to talk about what you should see. So let me go through this, and then if there's still questions that are there and they haven't been answered, we can go through those. Does that sound fair enough?
Yep.
So the slide you should be seeing, it says, what is the ideal placement for a PE-GJ? That should actually say a GJ. And then if there's endoscopic and radiographic evaluation. So I want to show you this. So let's pop down to the next slide. There's a cartoon on the left, and most all of you have seen a stomach on a cartoon, and you can see on the right-hand side of that cartoon at 3 o'clock is a PEG tube, and then you see extending from the PEG tube through the stomach down to the pylorus, which is the bottom of the stomach, into the small intestine, which is that tubular structure, is the J tube. And so, as I mentioned, this could be a two-piece system where the G tube and the J tube are molded together. They're all one piece, although there's still two openings, one in the stomach, one in the small bowel, or a two-piece system like I had mentioned to you. When you go over to the right-hand side, this is a little more difficult, but this is what we look at when we're done, if we're not confident that we've placed the tube directly. And you can see I have something on the right-hand picture, the radiograph, which says PEG tube. And we can all see that label there. And if you look at the PEG tube and you follow it up towards the middle of the radiograph, you'll see a little circle. That's the balloon or the internal bolster in the PEG tube. And then you see a little thin white line coming out from there and folding around and then coming back over to the left side of the X-ray. That's the J tube. And so what I'm showing you here is that you have a PEG tube and then you have a J tube extending from that. And the J tube goes around the duodenum and then over towards the jejunum. And I'm not going to go through all the landmarks here, but this is what I would look at to say this PE-GJ system is perfectly placed, what I'm seeing on the right-hand side here. And it's very easy for me to know that your tube is in the correct position if there's ever any concern. That's, if you go to the next slide, 7, this is what you see from an endoscopic image. So this is the inside of the stomach. And if you can look on the right, what you're seeing is the internal bolster of the PEG tube. And you're sitting in the stomach here. And you can see how I have it labeled PEG tube internally. And then you see a dark hole down on the right-hand side there that I have labeled pylorus. That's because The PEG tube's in the stomach, and the pylorus is downstream there. And what I want is for the J tube to go through the PEG tube and then down through the pylorus. If you go over to the right-hand picture, again, it's the same PEG tube I was showing you in picture A. Now in picture B, you can see the PEG tube, the internal bolster on that, and then look at the J tube. It goes directly from the inside of the PEG, and then you see it heading downstream. It's going down towards the pylorus and then out into the small bowel. The major thing I want you to take away from here is there's no loops of the J tube. I'm going to show you what I mean by that. The J tube goes directly from the PEG into the small bowel. It's a direct path. There's no looping. Let me show you what I mean by that. If you look at slide number 8, which hopefully you're seeing now, and then it says direct pathway from PEG to pylorus. I'm showing you this again. It's a different type of PEG tube. This is pictures H and I. You can see the internal bolster and then the J tube, and you can see it's heading directly down towards the pylorus in pictures H and I. So what I call this is no J tube looping. And the reason I'm mentioning all this is most of the time when I see GJ tubes that are having issues, it's because they were never placed appropriately the first time. So when you look at slide number 9, again, in the upper left-hand corner, you can see I said this is correct, direct pathway to pylorus, no looping. You can see that. There's the PEG tube in the upper left-hand corner and the J tube directly into the, going down towards the pylorus into the small bowel. Now look at the pictures on the right. You see the PEG tube on the right, on the top right-hand corner? This is around at 1 o'clock on the slide. You can see the PEG tube sitting there in the stomach, and then the J tube, you can see, doesn't go directly down to the pylorus. It loops in the stomach before it goes down into through the pylorus. And if it's left like this after placement, it will be in the small bowel to start off with, but because this loop is in the stomach will contract on that loop and typically pull the J tube back out of position. In fact, if you look at the very bottom of the slide, it's labeled B. You can actually see a J tube that not only pulled back into the stomach, you can see that it's looped, but it's actually knotted itself within the stomach. And that's because your stomach is very, very mobile. It contracts very vigorously, even if you're not eating and drinking, assuming you don't have a severe gastroparesis. And it can actually tie a loop in the tube. So one of the things I wanted to mention to this group here was that, look, these tube systems do work. However, if they're not placed the correct way to begin with, you're going to have problems. Rosalind, I don't know if that was you or Joan or who else was there, but I have a slide to go to next, but I want to stop here because that was a lot of information to see if there's any questions.
It's Lisa, Dr. DeLegge.
Oh, Lisa, I'm sorry.
Yeah, that's okay. How would you know? So there are a lot of questions.
You want to pick one or two, Lisa, that you want to pick off the top?
Yep. Let's see. One is asking if dangler GJs, the longer tubes, work better than low profile devices, GJs.
Yeah, so here's what I would say is the G port on a dangler is bigger than is the G port on a low profile GJ system, because you have to actually hook up to the G port on a low profile, and that's a very narrow opening, so you may not get quite as good of decompression of the stomach if that's your goal with a low profile device as compared to the dangler. Okay,
and that would be a legacy dangler, I'm assuming, as opposed to an ENFit, or does it not? Okay.
Correct, for legacy. Yep.
Okay. Claire says, I have a GJ that is a 16 French. Is that abnormally big? You were saying that most GJs are 9 to 12 French.
Yeah, so what I was trying to say is years ago, we used to think you had to put in a smaller tube into the small intestine. It was just kind of information passed down over the ages from physician to physician. And what we've learned in the past 20 years is that's just not true. So, you know, a 16 French or an 18 French or a 20 French into the small bowel is very well tolerated. So 16 French is fine.
Great. Thanks, Dr. DeLegge. Anna says she opted for a GJ over a J because she had concerns about the safety of J tubes, especially since her small bowel is the only part that's normal and she has a delayed colon. What are your thoughts about the safety of J versus G?
Yep. Great. These are great questions. So here's what I would say is that I have found the J tube. So if you need a J tube and you need it forever, as I mentioned to you, I thought you probably should just get it. You know, a tube directly into the small intestine or a J tube. However, you know, I can never say always. I've had patients of mine who have had GJ systems for years and not had any issues. So I'm being very broad brushed about this. You were right. The J tubes tend to be more commonly associated with leakage, peritubular leakage, and more commonly associated with inflammation and infection than is the G tube. You know, if we look at all J tubes placed in all G tubes, that is a well-known fact. And so, if in fact your J tube's working for you with your GJ system, and you're not having any issues, I wouldn't change.
Great, thanks. Anna also asked if, and she's saying thank you very much in the chat. Sorry, my question just disappeared. I'll go to a different one. Is there a way to weigh and or test to specifically see if G-tube is in place or not?
Yeah, the only definitive test is an X-ray. I mean, you can do endoscopy again, but that's not. You don't need to do that. It's an X-ray.
Okay.
That's the only real way you can tell.
Okay. And Anna asks, this is in reference to a slide. I'm not sure if it was the slide. I'm not sure which slide. Does placement toward the center of the stomach, like in the first diagram, help avoid looping? Yeah.
So here's what I would say is, and then again, this comes to the endoscopic placement. So when you have endoscopy and you're inside the stomach, and you can kind of pick and choose where you want to go against the the gastric wall, meaning you're inside. So you're kind of on the inside looking up, and you're kind of choosing your spot. So I tend to choose a spot that is lower in the body of the stomach. It is very technical, but I do choose a spot that makes it less likely to have looping occur just based on my experience. And I can do that endoscopically. My personal opinion, and maybe a radiologist would argue with me, is that my radiology friends, I don't think have quite the ability to do that, just simply based on the fact that I'm looking directly versus they're using imaging to look.
Great, thank you. Sorry?
No, go ahead.
Okay. Elaine, one more question, then we'll let you finish up, and I'm sure we'll have a few more. This is a wonderful topic. Thank you for addressing it. Elaine mentions that in Canada, they have IRs inserting multi-purpose tubes, like drainage tubes, as feeding tubes. She's not sure why, but she's wondering what your advice might be to help change practice.
Yeah, so, you know, you're probably right. And my experience has been, and this is with radiology, is that they do use multi-purpose tubes to place a feeding tube in, such as into the small bowel or into the stomach. And so it's a tube that was originally manufactured for, say, drainage, for like draining an abscess, or maybe it was a catheter to drain your chest cavity. And now they're using it as a feeding catheter or a drainage catheter. Those systems, by and large, first of all, are not, in my mind, designed to work with the ENFit systems. That's one. Number two is they tend to be very much smaller in size than I like. This is especially for the J-tube systems. And the third thing is the materials that are used often could be different than what's used in a PEG tube that's meant to be a feeding tube, or a jejunal tube that's meant to be a jejunal tube. And I've seen more issues with irritation and inflammation around the tube site where it goes in, and in fact, an infection. And it may just simply be the materials that are used for that are stiffer than what are used for feeding tubes.
And do you have any suggestion for how consumers can drive
Yeah.
change?
What I would say to your radiologist is that I want if I want a feeding tube system, I want a feeding tube, a radiology tube system that is designed to be a feeding tube, not a tube for some other indication that's being used for feeding.
Thanks, Dr. DeLegge. If you'd like to go on and complete your presentation.
Okay. I'll finish up because I said to this crew today that the two biggest issues with the GJ system are, one, clogging, and so if I had to pick a GJ system with a 9 French tube or a 12 French, I would pick the 12 French personally if I was a patient, and I give that to all my patients. I tend to use the larger tubes because I don't like clogging. The other piece that I said to you was migration. And I'm sure all of you have heard the word migration or movement, or it's in the wrong spot. And I had mentioned to you that if you don't put it in right to start with, it's going to migrate back into the stomach based on those pictures I showed you. But it would ask any patient or any person would ask questions as, well, why can't they change the way the J tubes are designed so they don't migrate? So if you go, it says the current slide should say modifications of jejunal feeding. If you go to the next slide after that, you're going to see, and this is a slide which is full of data, but I'm just going to walk you through this. This is slide 11. And basically here, the question would be, well, why not put a weight on the end of the J tube? So if you take your J tube, why not manufacture it with a weight on the end? And then the weight should help it hold it in position once it's placed there. And, intuitively, if you think about gravity and such, that may make some sense. The reality is here, and I have that red box outlined there where it says p-values. P-values means if it's statistically significant. I know this group has heard these words before. If you're less than 0.05, it means something. But this is a study that basically looked at weighted versus unweighted jejunal feeding tubes and said, okay, is there a difference between the two as far as how long these tubes last? I mean, they don't migrate. They don't have problems with migration and misposition. And the bottom line is there was no difference shown between the two, meaning the weights didn't help. We saw that also with nasal jejunal tubes in the old days when we would put tubes in patients in the hospital through their nose down into their small intestine. We tried weighted tubes, and although it seems like it should make sense, it hasn't resulted in any improvement. Now, on the next slide, there are some systems that are being looked at that actually have a balloon on the end of the J tube. So if you can imagine your J tube sitting down in your small bowel, and some of you might say, well, why not just blow up a balloon on the end of the J tube while it's sitting in the small bowel, and then it can't migrate, can't come back. And it sounds reasonable. The problem is that the balloons themselves, when you blow them up in the small intestine, you have to be very careful because you can completely block the small intestine with the balloon, meaning the stomach's huge and the small intestine is small in diameter. And so these balloons can actually lead to obstruction and then nausea and vomiting. There's been one study that's looked at this. They said that the tubes were, they only placed 7 of these tubes, and they had technical success. They only followed 2 of the 7 tubes long term. It wasn't a randomized study. 30% of these clogged. And so we really didn't get any valuable information here. But, if you said to me, hey, I have a J tube that my manufacturer has, and has a balloon on the end, and, should we be using that? My answer is it should only be done by somebody who understands J tubes, very knowledgeable in placement. And to date, there's just no evidence that the balloon does anything. If some larger study comes out in the future and I read about it, I'd be happy to bring it to the group. You go to the next slide. And so the last thing people will say is, well, why not just clip it in position? So if you're doing these endoscopically, you can take the J-tube, as you can see there in the pictures A, B, and C, and you can put a little suture on the end of the J-tube, and then you can take the J-tube suture and then clip it to the small intestine wall. And voila, here's a study that was in 31 patients. They had good success rates, and they had follow-up only on 20 of the 31 patients. And they had a very short follow-up of 59 days. They said the J-tube system with the clips worked. But, you know, in fact, the data on follow-up was really no better than what I see without a clip. And these clips that are done endoscopically are not meant to be permanent. They last for about 4 weeks and then they fall off the lining. So it's a very temporary solution for that. If you go to the last slide, and I hope I didn't go too far over, what I was going to say to you is that my conclusion is that the PEGJ, it's a very effective feeding system, and you can decompress and you can feed. However, the J-tubes are prone to occlusion because they're 9 or 12 French and migration. I will say to you that part of the problem is people putting in the tubes that a properly positioned J-tube through a peg, unless someone's having just tremendous amounts of nausea and vomiting, or someone yanks the tube out, they don't migrate if they're put in position correctly originally. I don't see any advantage of the weights, and really I don't see any advantage of the clip-assisted or the balloon tip J-tubes with regards to prevention of migration. I'll stop there, and I don't know whether, Lisa, if I run over time or if there's any further questions I can help with.
You're right on time, Dr. DeLegge. I will sneak in one more question until Joan moves us to the next topic. There's one question, and I encourage people to email me, and I'll try to get questions, Dr. DeLegge, too. But here's Sheila asks, if my GPEG was placed 3.5 years ago and it rubs constantly against my lower left rib, is it a big deal to have it placed in a different area of the stomach?
No, it's not. And I would encourage, I think you said her to do that, because underneath your rib is our blood vessels, but there's nerves. There, that's where the nerve and blood vessels run underneath your ribs. And so that can be really painful. It can limit mobility, and really it's, from my perspective, it's not a huge procedure to go back in and just have it replaced in a different spot, pull that one out, and the original opening will close up.
Terrific. Thank you, Dr. DeLegge.
You're so welcome.
Dr. DeLegge, I have to say this community drinks from its saucer because our cup has overflowed with information. Thank you so much for tackling this this topic that's for the most part, I think, overlooked. And I think we should probably make a commitment now to follow up.
It'd be great, Joan. I'd love to take on any questions people have. Please feel free to email them through Oley, and anything I can do to help, just let me know.
Well, thank you so much. Maybe we'll start drafting a list, and we could post the answers online.
That sounds great. You all take care and have a great meeting.
Thank you. Thank you. Same to you. So, bye. And now we're going to move on to a video from one of our corporate sponsors. Don?
Advocacy department. This is Carl speaking. How can I help you? PIQ stands for Partners in Quality, and what that means is we partner with our internal and external partners, clinicians, physicians, patients, parents, and customers to provide assistance with any quality issues or technical problems that a patient or customer may be having with our devices. There are 6 members of the PIQ team. There are collectively about 190 years of clinical experience, and with that background, we're able to provide a holistic level of care to our patients who are using our devices. The team takes phone calls and emails throughout the day from our end users, patients, parents, customers, physicians, distributors. We can assist them in getting proper use and fit for their devices. And then we can answer any troubleshooting issues that maybe a doctor or a nurse may have when they're using the device. We are that first line to assist through a phone call. What I love most is being able to provide care to our patients and to provide help for someone in need at that time who may be having a difficult day or a difficult time using their device. It gives you joy when you hang up that call or when I close that email that you've helped someone to make it through a difficult situation, to make their life and their day better, to get back to those things that really matter.
Joan, could you unmute yourself?
I'm unmuted now. Our final presentation of the day is again with Cynthia Reddick, this time for a show and tell, all about feeding tubes, tubing, syringes, etc. that go with them. Cynthia?
Hi, everybody. I'm back. All right, let's dive into next subject, and I'm going to do, I've got a little lab set up here, so this should be fun. I'm going to do just a quick overview of what we're going to talk about, and then I'm going to share hopefully some nice like demo, like a nice perspective for you all to see. Try this. There we go. Okay, so I know there was a question, I think it's in chat now, but my email is up here again, just so you have my information. And this is one of my favorite things to talk about. I love talking about tubes, and I think it's, for the clinicians on the call, it's fun, especially if there's any dietitians on here. It's sort of eye-opening because we don't get a lot of that information and experience when we're in the hospital setting. It's when we get into home care, we become, it's necessary to understand how to troubleshoot and things. So, and I think that, you know, for you as consumers, again, I can't emphasize this enough, this is your prosthetic. So I want you to think about it like, if somebody were having a prosthetic leg or hand, it is customized and fitted and designed to meet your needs. And I want you to think about your feeding tube in the same way. It's not, you get what you get and you don't pitch a fit, you know, you get to have a say in this, and you kind of get what you get the first time, but then once you've got your stoma and it's mature and you're able to navigate through the healthcare system and have your tube changed out, you get to advocate for yourself. And so, you know, Rick talked about it yesterday with, you know, his lifestyle. He's been able to live a rich and full and active life because he has customized his prosthetic, his feeding tube, and the way he feeds to meet his lifestyle. And so I hope this information empowers you to think about your feeding tube in that way. And I hope it opens the eyes of any clinicians on this call to think about the feeding tubes in a different way, because it's not a one size fits all. You have to meet the device to, you know, match the device to meet your needs, and everybody's needs are different. So, all right, so here are my disclosures. And I was thinking a lot about how how I wanted to approach this, and I like to know what the needs are from an education perspective of my audience. And so I started asking consumers that I communicate with, what do you wish you had known earlier in your journey with a feeding tube? Because it's a very rushed experience. When you first get a tube, there's not a lot of information. You are solving problems on the fly, trying to figure this out. Sometimes you have a lot of support and education, and sometimes you don't, right? So now here you are looking back at your former self and thinking, okay, if I had known this earlier in my journey, it would have impacted my life. And that's my goal, is to share information that helps you thrive on your journey, but also, and most importantly, have a good relationship with your feeding tube so that it's not this problem and challenge and obstacle, that it just becomes, it's your prosthetic, it's what allows you to thrive and live a rich, full life. And so that's the tone that I want to set starting this presentation. But let me just kind of cover some of the answers that I got. I'll share this with you. So one of the answers was, I wish I knew what my options were as it relates to feeding tubes, because you don't get, you're not given a menu when you're in the procedure room. Say, which one would you like? Which one do you think would really fit your needs? And they're just not thinking about that. So once you know what your options are, then you get to self-advocate, right? So other responses were about the ENFit design benefits in the home setting, and Vicki did a spectacular job of that earlier today. So I think we've covered that. How to best care for your feeding tube and your tube site, and Mary covered that yesterday as well. So, I think we're doing a really great job. I didn't share my survey with Oley before this presentation, so I'm here to tell you I think we're on target. And then lastly is there's always questions about low profile tubes, because most people get a dangler. When they first have a tube put in, it's unusual to get a low profile device on the first tube placement, but it does happen in certain circumstances. So people want to, get a little bit more information about how to get that low profile feeding tube and what all is involved. So here's my menu. This is what I'm going to try to tackle. And it's going to be fairly informal here. I'm just going to show you, I'm going to change camera positions. This is going to be a new format for me, where I'm going to kind of show you what I've got here in front of me. But I want to cover the following. So here's what I'm going to tell you. I'm going to talk about the anatomy of a feeding tube, how they're designed, what it looks like on the inside, because you usually can only see what's on the outside. I'll talk about the difference between a PEG tube, which Dr. DeLegge was illustrating some PEGs in some of the pictures in his prior presentation. So I'm going to compare a PEG to a balloon gastrostomy and what that looks like. I'll show the difference between the dangler style tube and the low profile device. And then I'm going to cover extension sets. So Lisa in her presentation yesterday was referencing right angle and straight extension sets, and not everybody knows what these are. So I'm going to kind of show you what the difference between the two and when we might use one versus the other. ENFit versus legacy port, I think we've covered that pretty well, but if it might come up again as I cover things. And then Lisa said something yesterday too, so I've been paying attention and taking notes, trying to think, like, how can I fill in some gaps here? She was talking about an O-ring syringe, so I'm going to talk about what that is, and also show you different syringe styles, because for our bolus feeding consumers, having options with syringes, and there are options, can sometimes be life-changing, believe it or not. And then I'm just going to cover the difference between small bore and large bore tubing. I'm going to show you the difference in extension sets and what the difference looks like in a gravity bag as well. So that's on my list. We'll get to Q&A later. Okay, so this is where it gets interesting. This is where I change my camera. I'm going to show you. Oh, it's not. I have the wrong camera on. All right, let's see if I can change my camera. Not gonna let me change my camera. Sorry, guys. Okay. Well, I will do it in front of the screen. So I'm gonna stop sharing. Okay, so we will start with the anatomy of a feeding tube. So I want to show you, I'll start with a balloon style gastrostomy tube. And this is a single piece. This has a balloon, which is the internal retention device. And then this is your external bolster. And it's important to know that these are adjustable and these move. So it's important to know, where a good setting is for your bolster so that you can have a nicely fitting tube. Now, when you look at a feeding tube from the outside, generally, you're not, when you've got the tube implanted, you can't see what's on the inside, right? So how do you determine whether you have a balloon style gastrostomy tube or you have a PEG style gastrostomy tube? And this is a PEG. So Dr. DeLegge was showing pictures in his last presentation with internal retention devices that look like this little bolster disc. And these are soft and flexible so that when it's time for these tubes to be removed, they're actually removed by traction. And so sometimes these tubes can get dislodged. They can accidentally come out, or patients can pull them out. So sometimes that's what I saw most of the time in the acute care setting. When these became dislodged, it was from somebody pulling on them, but that's not too common, thank goodness. And then this external bolster is what is adjusted to make sure that the tube is fit properly. And so when the tube is on the in place, and this is your stomach lining, you want to make sure that the tube is actually set so that the internal bolster, whether it's a balloon or this little soft pliable bolster, is resting on the inside lining of the stomach. And then the external bolster should be set appropriately. So we can get leaking at a G-tube site or a J-tube site if this bolster on the inside is sort of pushed away from the inside lining of the stomach. And so if it's not fitted properly or it's not adjusted properly, you can have leakage. So going back to the outside of the tube, which is generally all that you can see, whether you're a clinician assessing your patient or you are a consumer who is just trying to figure out what kind of a tube you have, the difference here is that you've got a PEG tube, which is percutaneously endoscopically placed, so it's placed in GI, only has a feed port and maybe a flush port or a med port. But the balloon style gastrostomies, which are all one piece, they have a feed port, potentially a med port. Some do, some don't have this extra med port. And then there's this extra balloon port. And so if you have a balloon port on your tube, and it'll have some writing on there that tells you the French size and how much water should be in that balloon, this is telling you that you have a balloon style retention device on the inside. So that's how you can determine whether you have a PEG, which is this guy, or a balloon style gastrostomy tube. And it's important for you to know what kind of prosthetic you have, what sort of device you have, so that you know what your options are when it's time to have the tube replaced. So when this one is removed, again, it's pulled out via traction out the stoma. When this one is removed, you deflate the balloon, and that's a fairly simple process with a syringe that's designed to fit in that balloon port. And remove the water. And then when it's time for that tube to come out, you just slide it out. And you can replace it with something like a button, if that's what you want to transition to. So this is your dangler style G tubes. Again, this is a balloon gastrostomy, and this is a PEG. All right, so now let's talk about low profile devices or balloon. And what I have one example of like balloon style buttons, and then there's lots of different brands and options. Well, not lots, but there's a few different brands and options, but there's different internal retention styles. Most of what I see used is this balloon style retention. And then there's a version that comes with a plastic soft internal retention. So there's nothing to pop and accidentally leak and then fall out, but it does require a little tool to stick in there and stretch this out for removal and replacement. So that's what that is. And then these balloon style tubes come in all different shafts and French sizes. So let's go over the anatomy of a low profile device. So this is your balloon port, and this is how you inflate and deflate the balloon. This is where you open up the port and connect your extension sets when it's time to feed or flush. This is the shaft of the button, and this comes in all different sizes. And so the difference between a dangler style tube and a balloon and a button style tube is that this has to be measured and sized to meet to fit you properly and to fit your stoma length. So I've got a couple different options I can sort of compare and show you the difference. So here is a 0.8 centimeter, just a little one for an itty bitty, and it's a 12 French. So the 12 French is telling you about the diameter or the thickness of this shaft, where the centimeters are telling you how long it is. So it's 0.8 centimeters. So this is designed for a little baby. And then here's a bigger one that has a 18 French. So the diameter of this one is 12 and the diameter of this one is 18. So you can see it fits a different stoma size. And then the length is 0.8, so just less than 1 centimeter, and this is 2 centimeters. And so you can see the difference there. So if you've got a feeding tube in a baby who's growing, eventually they're going to grow out of this one and they're going to need to go up to a 1 centimeter and then a 1.2 centimeter and then so on. And so they get resized and refitted as the child grows. And then for adults, these can be adjusted and resized depending on weight gain or weight loss. So that's important to keep in mind. And this information and understanding how to properly size a tube, a button style tube, is really important because it impacts the quality of life as it relates to leaking and any problems with tubes that don't fit quite well. Because if you have a tube and you have this much of it sticking out of your stoma, what that means is when it's all the way down here, what it means is when it's like fitted on your stomach lining like this balloon is far away from the internal lining of the stomach, and you can have leakage in there. So if you've got too much play between the inside lining of your stomach and the outside of your abdomen, and you can see too much of that shaft, then you're going to have more leakage and more problems. So you would need to resize your tube, and there are stoma measuring devices that can be used to actually measure your stoma tract. And so some people do that themselves at home, but most of the time that's done in clinic and they can be sized. So this little balloon deflates, you insert it into the stoma just like you're placing a tube or a button, and then you inflate this balloon with water, and then this little disc slides down until it's touching the abdomen and resting gently. And once it's got a good fit like that, you know it's not fitting. You don't want to size it when it's fitting like that, because then you're going to have way too much play, right? And you're going to have leakage coming out. So you want to gently pull and allow that disc to sit gently on the skin, and then you can read the measurement. There's little centimeter measurements on here. And the stoma measuring device needs to coincide with the brand, the manufacturer of the actual tube that you're sizing to fit. So that's what this is. And I find that sometimes these are used, but a lot of times I find that it's kind of a stab in the dark. If you're sizing, estimation, is a practice that I've seen with nurses and physicians that often they're very good at it from experience, but when sometimes I've seen it not quite as effective because the sizing isn't quite right. So that's when you might want to go verify your stoma length with a stoma measuring device. Okay, so let's talk about extension sets. So this is a right angle extension set, and this is what connects to the button to allow access for feeds. And right angle extension sets are called right angle because they have that little turn, right? They clip in and then they right angle. And you'll notice that the tubing itself is really quite narrow. So these are designed for pump feeding. This is not a good option for bolus feeding because it's going to slow down and make it harder to allow that formula to go through, whether you're pushing it or allowing it to go via gravity. So this is really designed for pump feeding or continuous feeding for two reasons. It's got that smaller bore size, which can help control flow, but it also lays conveniently off to the side and out of the way. So that's the main design feature of that extension set, is to get it out of the way. Now, a straight or bolus style extension set, these are great for water flushes because it can allow you to flush water through without a lot of resistance. And for drainage, so some people are able to drain or vent. This is a nice option. And notice the difference in the bore size, right? So this we would call a small bore. This straight extension set has a much larger bore, so it can handle more volume at a faster rate. So it's really designed for that bolus style feeding, especially if you're using thicker formulas. Right. We talked about ENFit versus legacy, and as a refresh, the buttons themselves are not legacy or ENFit. They're neither. They're agnostic. Okay, so the buttons have not changed in that way. It's really about the extension set and the end of the port, right? So here's this is a bolus style. This is your ENFit extension set, and then there are legacy extension sets as well. I don't have one handy. Okay, syringe styles, I want to touch on that. So this is a catheter tip or ENFit tip syringe, and this is the most common, where you can see this sort of plunger that you can have your fingers pull back on. But then there's also syringes that come with a thumb ring, and this can be easier for some people to manipulate just because sometimes hand dexterity can be an issue. So just know that you have options as it relates to the back end or the plunger of the syringe. And sometimes these things can make a big difference in your ability to feed and flush just because you're doing it on a regular basis. Then what you'll find, and I don't have an O-ring syringe here, but I want to describe it to you. So this is a typical gasket on a syringe. It's got this wide rubber gasket, but an O-ring syringe is a much thinner, more narrow gasket. And so it provides less friction. And those O-ring syringes, at least I was talking about that when she was talking about blenderized foods, because when you've got this larger gasket here, it can offer more resistance and can be a little bit harder to manipulate. But the O-ring syringes, it's not talking about this is a thumb ring, but the O-ring is just this rubber gasket is much thinner and more narrow. All right, so that's my syringe lesson for you. And then lastly, what I want to cover is the difference in gravity bags and large bore versus small bore. So with gravity feedings, you do have the option for a small bore bag, and the design is the same. So you have your bag, and this is a nice option for people who are pump feeding and want to transition to bolus, but you're maybe not ready, or your clinician is a little hesitant to allow that fast of a flow, you can use gravity bags with a small bore tubing to stimulate a pump. You may not need to use the pump for complete accuracy with very specific rates. You can have like an estimated feed time by setting this roller clamp and either closing it off to slow down the drip or opening it up to allow the drip of formula to go through. But I want to show you the difference between the large bore and the small bore tubing. Big difference. So this large bore gravity bag, when you put formula in there and leave the clamp wide open, that formula can flow through really, really fast. So you can't overdo it with this, but what I like about this option is it gives you the option to feed a little faster and you get to control the rate with the roller clamp, where with the small bore gravity bags, the only way to speed up a feeding is to dilute the formula a little bit with a little bit of water, not lots, maybe just an ounce. That can sometimes help formula flow through a little faster if you're using this small bore tubing. So let me pause there. I covered the anatomy of a feeding tube. I covered the difference between a PEG tube, a balloon gastrostomy. I talked about dangler style tubes versus low profile. Extension sets we looked at. We've covered ENFit quite a bit today, syringe styles, and then this large bore, small bore. So let me do a quick pause and check in with Lisa and see what kinds of questions have got your attention.
Hey, Cynthia, we have a lot of questions. Technically, we are, are you willing to stay a little later than we had originally scheduled to answer some questions? Are you able to stay with us?
Later if you
Terrific.
Yes,
Okay.
Yep.
All righty. Then we have a bunch of questions. We'll zip through some of the quick ones, I think. Somebody is asking, her button, her Mickey is very tight to the skin. It's 20 French, 3.5 centimeters. Could I just take a little water out of it so it is not so uncomfortable?
That is an excellent strategy for sizing and adjusting the fit of a button. So absolutely. And one thing you'll notice, here's a couple of examples. These are different balloon sizes. And they're also different button sizes, so they require a different amount of water. But I want to show you what that balloon looks like when it's filled with a good amount of water, and look at the shape of that and see how it's nice. And it's got this little flat aspect at the top. That is resting on the inside lining of your stomach, and that can adjust and make it it makes the shaft a little bit shorter. So if you take a little bit of water out, you can change the size of that, and it actually makes the shaft a little bit longer. So it can make the tube fit, give you a little room, but if you wanted to have it fit a little bit tighter, you can add some water and have it fit a little more secure. So that is absolutely an excellent technique, and something that once you're trained in, it's something that you can do at home independently, but you need to verify the fill volume range. So make sure you're not going too far out. Most of the time, buttons are a little bit underinflated, so they can be adjusted very easily. The other thing I want to say, because this came up in a prior, I saw a question somewhere about it, but what do you inflate this with? Obviously not air, but it should be distilled water, or distilled water, or I want to say purified, but that's not it. So no tap water, no saline. Okay, so you want water, distilled water, so that there's not any variation in chlorine or calcium amounts in the water that we have. So the manufacturers really want to verify and ensure that you have a less variables of inside the balloon, so that it doesn't rupture. But that was a bigger answer than what was asked.
Thanks.
That gives you, yeah, that helps you see that. And then this is, you can see the shape of this one, same manufacturer, different size, but see the shape of that balloon is going to completely change the experience of how it fits and how it leaks, as opposed to this sort of balloon shape. Does that make sense? So that's really important. And so get skilled at understanding balloon inflation. And also I want to say, I'm going off topic here, but I want to say too, before you replace your own balloon style tubes, before just popping it in there, this is a newer one. And so the balloon is a little stiffer. And when it inflates, you can see this. Do you see how lopsided this is? Let me get it to the right angle. So that balloon is completely lopsided because it's stiff and new. The silicone is fresh and been in the packaging. So you got to get in there and pre-inflate it and massage it, okay, so that it becomes round and completely covering the tube. Because sometimes when they're brand new, they just inflate like this. But you don't know that if you, the first time you ever inflate it, it's inside. So you want it pre-inflate it, massage it, get it all nice and symmetrical, and then inflate it. So all of these things play into the way a button, balloon, G-tube fits.
That's fascinating.
Is it just me that's nerding out on this?
No, it's great, great. So you have two questions about tightening. Well, these seem related to me. Maybe they're not. But as a clinician, how should we help or direct patients to adjust the external bolster without potentially pulling the internal bolster out or tug too hard against the balloon? And then there's another that's similar. I have a patient with a balloon G-tube that I suspect needs to be tightened. Is there a good way to do that myself without having to send them to IR?
So the second question again, it was a dangler, or does it
just says balloon?
Balloon. Okay. So if they could follow up by telling me if it's a dangler or not. But so it is a bit of an art. So when you're manipulating a tube, whether it's your tube or you're working with a consumer, it's really important to get a good handle. You've got to kind of get up in there real close. And as you're adjusting this bolster, when they're brand new, when these tubes are new, these are really stiff and hard to move. So the older they are, the easier they are to slide around. So you've just got to get kind of in there and have a little counter pressure. So when you're pulling this bolster back, you're not actually pulling the tube out. So you just got to get in real close. And you got to get your fingers in there and hold on to it to then, because this one's pretty new, so it's a little stiff, to then slide it out. So if you're paid, the second question, if you do have a consumer in clinic and you don't think it's fitting properly, you can absolutely work with the patient. You can even talk them through it. But the first thing I would do is have that, like, assuming that everything's inflated properly, is you want to pull that tube until you feel the resistance of the internal bolster, if it's this kind, or the balloon, until you feel that resistance, and then you want to set the external bolster, and there should just be a dime's width in there. Mary showed a nice little picture of a dime on her slides yesterday, just enough for a little bit of airflow. And that's how you know it's fitted properly. They don't need to go into OR procedure room for this adjustment.
Thanks, Cynthia. This one I know is something you feel passionate about. I have a low profile Mickey GJ and get a lot of leakage from my stoma. I wanted to ask my doctor if they could remeasure my stoma, since it's been 3 years since they first did it, but I also tend to lose and gain weight every few months. Should I ask them to remeasure?
So for the GJ, so you've got a I have one right here. So you've got a low profile GJ and it's leaking, not the right syringe, and it's leaking. So looking for my little syringe, I've lost it. So if it's leaking here at the stoma site, like it's coming out here, you can do that adjustment of the balloon fill volume like I talked about. What I find with, if it's actually in the stomach, you can go full size on the balloon, and I recommend on the upper end of the range for gastrostomy tubes. What I find about low profile J tubes, and I want to be clear, sometimes these are popped in the jejunum, and this can be a J tube. So there's some semantics that you need to be really clear on. From a supply management perspective, this is a G tube. That's what we call it and how we order it. But when it's placed anatomically into a direct jejunal stoma, it is acting as a J tube. So not knowing the other details of this person's question, what I would say is have an understanding. I find that direct J tubes with balloon buttons like these, there is an underinflation of the balloon because of a concern about blocking the intestine with this balloon. So I find that they are often on the low end or and even under the recommended range. So that's one where you would want to be really clear, and they leak a lot because of that. So I see a lot of leaky J tubes because of this underinflated issue. And so you have to sort of work with your physician and sort of tinker with what their tolerance level is on the inflation of the balloon, but then also making sure that it's the right stoma length. It's so simple to measure. All you need is one of these. And if your IR department doesn't have one, have them order it. It's not difficult to get, and measure. So the next time you go in for, and that could be something you do once a year, twice a year when you go in for replacements, is ask them to measure, or get one of these and bring it with you and have it used to actually measure your stoma site. This is your prosthetic, and you have a right to understand the size of it and making sure it's functioning properly. So you get to advocate for yourself in that way.
Thanks, Cynthia. I think we'll go with a few more, and then I know that we did put your email address in the chat. So so watch your email.
Okay. I'm going out of the country in 2 days. So if I'm delayed in answering questions, just putting that out there, hang in there with me for a few weeks.
And Cynthia always, she's very reliable, tell you that. Cynthia, Bethany asks if you can use a button as a G-tube to decompress your stomach, or if you need something different.
Yes, in fact, people use buttons all the time to decompress. So they're absolutely, you can. I would say for draining, I'm going to disagree with Dr. DeLegge on this a little bit. I think that, and I'm going off topic here, but sort of the same topic. So venting, absolutely, this can be done to vent your stomach. Draining, I find that for some people, depending on how much volume, how often they need to drain, and if there's food involved in the drainage, that going to a dangler, regardless of connector type, whether it's Legacy or ENFit, a dangler works better. So I don't think it's so much ENFit versus Legacy port. I think it's button style versus dangler style that makes the bigger impact. Okay, that's my comment on that. Yeah.
I don't know if you can answer these. These are a couple of reimbursement questions. Maybe in a general sense you can.
Okay.
One is, are the ENFit drain bags reimbursed?
Oh, I saw that question. So drain bags, here's how it was for me. I used to work for an infusion company, and so we had infusion contracts, and if somebody was receiving tube feeding and we were billing for the tube feeding and they also needed drainage bags, we would provide them as part of their enteral supply kit. And we get reimbursed for an enteral supply kit, either via per diem or a daily, rate, or as a supply code level. So if you're tube feeding and you need drain supplies, we don't bill specifically for the bags themselves. It's more of a supply kit, if that makes sense. And so then we have to manage the expense of all the supplies that are being sent and compare that to actually what's being reimbursed. So sometimes we're okay and sometimes we're upside down. And So when you ask, is it reimbursed? It's kind of a tricky question because yes, but maybe not enough to cover the expense. So that's my answer to that.
Okay. That's
Oh, let me finish. There's more. So if we're an infusion company and our contracts are, we get paid if we're providing feeding, but we've been asked to provide only drain supplies, we don't actually get paid for that. So a DME provider has a contract that will actually allow for reimbursement of what would be called DME. If all your durable medical equipment, if all you're doing is draining, then that DME sort of payment methodology works, and that's where we would have to send people is to a DME company in that instance.
thanks.
But that's this technicality between an infusion company and a DME company. We spent an hour on that.
Right. I think, yeah, whole nother topic. That addresses Terry says that she uses urinary drain bags and she buys them on Amazon and uses Hypofix to connect them and everything's paid out of pocket. So I think you've kind of gone into that with the DME thing.
Yeah.
Okay.
Yeah. And they're reusable. So it can be done affordably in that case, thank goodness, as opposed to feral bags. Forget about it. It can put you upside down really quick trying to pay for those and use a new one every day and get reimbursed for it. So drainage, if you can use urinary drain bags in that instance when you're having to pay out of pocket, that's the way to go.
Great. This one is specific to your presentation earlier. It's what is the name of the purple/clear connector for an ENFit G-tube and urine drain bag?
Read this. Enteral funnel ENFit transition connector with cap. Here it is.
Okay.
But it's
Terrific.
just an ENFit to legacy adapter. That's the other thing you could call it, because there's multiple brands of these, but this is the one that I have.
Multiple brands and they look a little different, right?
Yeah, there might be different colors or things, but here's your ENFit connector to your feeding tube that then turns it to a legacy port. So ENFit to legacy is what you would call that.
Great. We're working on an educational piece, kind of has a lot of photos and an infographic.
Photos are good.
So
you know how
yeah.
much I love photos. Yeah.
Yes. Yeah. Photos in this instance, they're really, you can't get around it. You need them.
Yeah.
So I think this will be a relatively quick one. Can you drain out of a J tube? This maybe was for Dr. DeLegge, but I ask because sometimes when I disconnect my feeding tube, stomach acid or yellow gastric juices comes out.
Yes. So it can drain. You may not be wanting to. So if you've got an obstruction and something's pooling in your intestine, if you think about it, the stomach is a reservoir and it's got this little control, the pyloric sphincter down at the bottom of this reservoir is like a time release thing that lets things drip out of the stomach into the intestine. And it's going to happen all day, whether you're feeding or not, right? Because your body's making bile and stomach acid and that's all making its way through. So whether you're feeding or flushing or not, you could have liquids flowing through your intestine. And so it's absolutely J-tubes can leak, especially if you're in a time where you're just making a lot of gastric juices or there's just been a release of some of your gastric contents. But it's not something that you probably want to do is drain out of your J-tube unless that's the intervention that is needed. But I haven't seen an intentional prescribed J-tube drainage procedure.
Thanks, Cynthia. And speaking of drainage, how often does a gastric drainage bag need to be changed, and how do you clean them to reuse them?
Yeah, so you can reuse them as long as you're comfortable. I mean, they are reused for urine. You could do one a week easily. So what you would do is just connect the bag. You could connect a syringe and fill water in there and just let it flow through. So you could just use warm water in that way. Same with the ENFit, but they don't need to be sterile, and you don't need fresh bags necessarily if you're going out and about and you don't want to deal with or have a sort of a used bag be seen. Then you might want to grab a fresh one if you're going out and about for that. But at home, they can be rinsed and reused as long as you're, in my opinion, as long as you're comfortable with it.
Thanks. Okay, last one. And then I would encourage people to email Cynthia again, or email me and I will get them to Cynthia. Both of our email addresses were in the chat. So here's our last question, Cynthia, and hate to let you go, but is it hard to pull up meds? Oh, sorry, it's a statement. It is hard to pull up meds from a med cup with a short ENFit end of the syringes. I have attached a stepped adapter. Is there a better method, or are there syringes with a long end like the catheter tip syringes?
So this is the procedure she was talking about. Here's like a med syringe. This is a little 5 milliliter. And this is kind of funky to, you know, get meds out of the bottom of a cup, a med cup. So if you put your little transition connector on there, you have this nice easy tip, and then it can come up real nicely. So when you pull back, you might have some medication still in the transition connector. So sometimes that's a major issue, especially if it's like a narcotic or something that's very precisely measured. I've had patients who like couldn't have any waste because of their pain management and the limitation on medication. But then once you take that off, you can connect and push through. There are, and I don't have any with me, and I think there's info on the GEDSA website about medication administration. There's little bottle caps that basically goes on the medication bottle. If it's a liquid med, right, it is, I think, or maybe not, maybe it's crushed and flushed, but if it's a liquid med that's coming out of a bottle, you can put this little cap on the bottle and the syringe plugs right into it, and you can draw back nice and clean. And then there's the straws, the medication straws. Was that part of the question, the straws?
Nope, but it fits right in.
Okay, yeah, the medication straws are cool because you can connect on there, and then it just draws it up right through a straw, which has this teeny tiny little bore that'll get down into a bottle or into a little cup if you're doing the mixture with your mortar and pestle and water. So that works as well. But those, a lot of home care companies aren't providing those. I think this was touched on in Vicki's presentation. So that's where I really encourage you to go online and shop around and find some options, and you can wash and reuse those. So it's just should be part of your supply kit.
Right. And they're bottle adapters as well, right?
Yes.
Right. Okay. I don't know if Joan is ready to give our closing remarks. If we don't hear from her momentarily, I'm going to jump in with another question. You know I am.
Yeah. Well, while you find a question, I think Joan just came off mute, but I want to say something before Joan starts, because I haven't had a chance to say hello to you yet, my dear. First of all, I want to thank you for, I was very mindful of this yesterday. I just want to thank you for your legacy and the way that you have set the intention of this organization, this community. It's a family, and it started with so much of the work that you've been doing over the last many decades. And you are handing off a beautiful legacy to Beth, who gets to carry it forward. And I'm so grateful to be a part of the Oley family, and I feel very privileged every time I get to speak to this community. So thank you for having me and welcoming me every time.
Well, Cynthia, it's hard to follow that, but thank you. It's people like you who've kept me inspired, kept my brain stimulated, and I'm just hoping for more of it as I rotate into the new role. And I know we'll see each other.
Yes.
Not
yes.
once, twice, maybe a dozen times, maybe too much. I can promise you that.
Yes,
So
and you mentioned this at the beginning of the conference, how your role will be identifying the next in-person location, which I think is part of the fun that you have with that, is sort of setting the right environment, and I can't wait. So I'll be counting you around February, March of next year to find out where these festivities will be in person. So with that, I want to go off camera, but thank you all very much for your time.
It's all fun. And thank you to Cynthia, Reddick, and all of today's speakers for the tremendous amount of information. And thank you to the attendees for the fantastic questions and interaction today. I'm unbelievably overstimulated. I don't know what time I'll fall into bed tonight, but I also want to give another nod. Thank you to the corporate sponsors for their support. A few reminders: be sure to check out the marketplace and take the 3 challenges. Consumers and caregivers 18 years or older who score at least 80% correctly will be entered into a drawing. 5 lucky winners will be able to choose a great prize. Clinicians are welcome to take the challenge for a fun learning experience. I think that statement speaks volumes to the fact there are no prizes for clinicians. Links to the challenges are should be posted in the chat, Oley.org/marketplace 2022. And you must complete the challenges by 12:30 Eastern Time, August 18th. That's tomorrow, if I'm not mistaken. Winners will be announced at the closing remarks tomorrow. Meet the Oley ambassadors, and the Spouse Connection social hours will begin at 3:30 promptly. And the links are posted on Oley.org, Oley2022. Please complete the conference evaluation. Your feedback is so important to us and drives future programs. So you should get an email from Zoom with a link to the short survey. Additionally, if you're using Zoom through a web browser, you should get a prompt on the Zoom screen as you leave the meeting. Another quick reminder, join us tomorrow at 11:45 a.m. on Eastern Time for the Intestinal Failure Workshop, another full day of information and connections. Thank you, thank you, thank you.